Good afternoon, everyone. Thank you and welcome to the Benzodiazepine Withdrawal Symposium. My name is Mano O'Connor, and I'm the Senior Director of Development for the University of Arizona College of Medicine, and it is my pleasure today to be the first person to welcome you to this very, very important symposium. It is also my pleasure to introduce to you our Interim Dean of the University of Arizona College of Medicine and the Senior Associate Vice President for Health Sciences here at the University of Arizona, Dr. Irving Kron. Thank you.
I don't quite have my dean clothes on, but I'm sure you'll forgive me. So I'm thrilled we're having this conference. I actually have a personal interest in this. I have a family member who's had a Xanax issue, and I learned the hard way just how difficult withdrawal is from this drug and how ubiquitous the use is. It's when you look at the numbers, it's beyond belief. And you know, the timing of this probably should have happened 5 to 10 years ago, but I'm thrilled it's happening now, and I'm thrilled it's happening here. Before I go on further, I want to thank several people who are here for helping us with this. Dr. Bob Roffa and Dr. Joe Pergolizzi. Joe, I hope that's got it right. And the help from the NEMA Research Alliance. And I also want a special welcome and thank you for Carrie and Bernie Silvernail and the Alliance for Benzodiazepine Best Practices. So we're really grateful for your leadership. The timing could not be better. It's a huge problem. I know we focus a lot on opiates, which is the front page news story, but I believe this problem may be even more severe. So without further ado, I'll call Dr. Roffa up to speak, but thank you so much for being here.
Thank you very much, Dean. That was a very nice welcome. And good afternoon, everybody who is here, and everybody to whom we're transmitting this symposium this afternoon. Two years ago, to this very day, a remarkable and deeply moving symposium was held in Bend, Oregon, titled the International Benzodiazepine Symposium. There were 19 of us invited speakers and an audience of about 75. On the surface, it was just a typical symposium, but it was actually not at all typical. It was organized, financed, and run by patients, their loved ones, and their supporters. They did it all. It would not have occurred without them. An important purpose of this was to provide a safe environment. Think about that. A safe environment in which to participate in patient-doctor and patient-researcher interactions and discussions. None of the speakers was truly an expert in benzodiazepine research because there aren't any anymore. Many of us speakers were initially, quite frankly, skeptical, right? Who are these patients? What are their difficult to characterize, let alone explain, symptoms that seem to have no ready or even logical pharmacologic explanation? Maybe there were other non-physiologic explanation for their symptoms. But the more we listened and the more we restudied the literature, we were surprised. Now, we were shocked to learn that the data are there, and they always have been. And it has been known for a long time. But more than that, there is now new basic science evidence that you'll hear about from one of the researchers here at the university that supports what the patients have been saying that they experience. Each of us who presented had taught the supposed clinical and basic science knowledge of benzodiazepine and the Z drugs, the pharmacology and the prescribing for many, many years. We all did. Little did we know just how little did we know. The Benz Symposium revealed to us a little-known, neglected, and commonly discounted, disregarded, or even belittled aspect of either taking or discontinuing benzodiazepine-like drugs, a very protracted and mysterious withdrawal syndrome. We became motivated to look into the patient's concerns closer, and the purpose of today's symposium is to tell you about our journey and what we learned to our surprise. We thought that it would be quick and easy. What we found instead is that we know a lot about the efficacy and safety of benzodiazepines, which are nice drugs, for up to about 4 weeks. We know a lot about them, and you'll be hearing about that today. But not beyond 4 weeks. There's almost a complete lack of information. We don't know. Could be good, maybe not. We just don't really know. So beyond 4 weeks, or even a little less, we felt like Alice through the looking glass. So that's sort of the theme today. It's a world of unknowns, full of surprises, some unpleasant surprises. So our intent today is to present what we found, and as a result, to shed light on the concerns regarding the negative aspects of benzodiazepines, which surprisingly have been known almost since the beginning, but they have been largely forgotten or ignored. We were surprised. We think that you will be surprised as well. So a quick word about the agenda. I'll be talking a little bit about the basic pharmacology, but first we want to share with you some patient experiences. So Carrie Silvernail will be just giving you some background about her personal experience. And one thing you notice is we selected some presenters who have medical background. So these are folks who understand these drugs, they understand the physiology, and we think they have special insight. Now, the second patient story we had to be announced because we, quite frankly, couldn't commit, and that's really I think nothing better highlights the situation. We had, 3 other speakers lined up, a physician in the Tucson area, and 2 others who were going to fly in from Dallas to try to explain to you their situation, and hopefully you listen. None of the 3 could make it because of their problems. So I left it that way because I think nothing speaks louder to what they're facing. Then we have Dr. Pergolizzi talk a little bit about the clinical aspects of things, particularly with the use of benzodiazepines for pain medication. And Dr. Wright will talk a little bit. He has experience with helping through the withdrawal process. And then our special local guest, Dr. Vanderah, who is the head of the pharmacology department at the university, he's doing some basic research in the area that he will describe. And as far as we know, he is the only basic science researcher working in this field at the moment. So I would also, like the dean, I want to thank the dean, first of all, for that nice introduction. I have some people I'd like to thank. So from the university, Manon, Lupian O'Connor, Senior Director of Development. You saw earlier today Ross Dubois, who's Manager of Special Projects, has been an absolute tremendous help to us. Dr. Vanderah for his many courtesies here and leading the tour of his lab, et cetera. The Alliance for Benzodiazepine Best Practices is a wonderful web page, and they have I don't know what the right word is, put their money where their mouth is. They are family members, patients, and they are sponsoring symposia and basic research and the like. And there's 2, I think they like each other from that picture. And so Carrie and Bernie are here. They will be available. Also, I want to thank Domenica Foti, Charles Wolmuth from NEMA, who have been involved in this and helping out a lot. I want to say our speakers today were carefully selected. I don't know if this is just a function of age, but I know together we have well over 1,000 publications, and we've all volunteered our time for this very wonderful cause. There's Dr. Vanderah on the right. He looks like he's at a wedding or ready to run for president. He's looking pretty good there. And then finally, I want to thank you all for showing interest and also for your willingness to look at the same thing with new eyes. So with that, I would like Carrie to come on up and tell us a little bit about her journey. We could leave it blank? Okay.
Yeah. Thanks. Oh, Dr. Roffa, thank you for that beautiful introduction. And boy, it was a surprise to see our picture up on the screen here. That was a photo taken a few years ago of my husband and I on our family farm in near Corvallis, Oregon. And it was fun to see that, so thank you. In 2012, when I learned that I was dependent on benzodiazepines, I set a goal for myself. And that was that one day I would stand in front of a group of influential people and share my story. And my voice is not alone. I am the voice of 1,000 more, if not more, people who are experiencing the same thing. So this is a tremendous milestone for me. And I thank everybody who made that possible. It took 7 years of healing and coordination to be here, and I am so deeply grateful. So I'll tell you a little bit about myself. I'm a wife and a mother and a grandmother of 2 wee ones and a new one on the way. We have a new baby coming in January. And I'm a retired nurse and a hiker and a chef and a gardener, a yoga practitioner, and all of those things were heavily influenced by exposure to benzodiazepines. In 2008, my journey with benzos began when I started having runs of irregular tachycardia that were very frightening. And I went to my physician, who quickly diagnosed me with generalized anxiety disorder and prescribed 0.25 milligrams of Xanax to be used as needed. He also said I could take it for back pain, because I was having a little bit of back pain. We lived on a farm and I was working hard. And he suggested that I start some stress reduction behaviors. And I did. I took a mindfulness-based stress reduction course, and I did more yoga, and I walked more, I hiked more on the farm, and I very, very sparingly used the Xanax because I was aware of the dependency issues. I knew that I could become dependent if I used it, and used it often, and I thought that if I used it as directed or less than directed, that it would be safe. Well, I was wrong. I continued to use it off and on, sparingly again, and for a couple of years, and the tachycardia continued, and I was eventually diagnosed with AFib and was treated for AFib and eventually had a cardiac ablation. And so that kind of took care of some of that anxiety. It was definitely related to the atrial fibrillation. So in 2011, I started having some pelvic pain, and I generally felt unwell. I started waking with a lot of anxiety and panic, and it would last into the day. I was unable to do my work well. I felt like it was interfering with my ability to provide safe patient care because I just felt so miserable. So I went to my physician again and explained what was going on, and she was very thorough in her approach. She sent me for a neuro consult. I went to gynecology. She sent me to a pelvic pain specialist. I mean, I had a very good workup: lumbar MRIs, pelvic ultrasounds, and everything was in normal limits. which was kind of disappointing. I was hoping that there was something that would show up that would indicate why I was in so much pain. And what was interesting about the pain is that it would kind of wax and wane, and it manifested in different parts of my body, but predominantly my pelvis. So it was quite acute, and it interfered with my life tremendously. And she suggested that I start on a benzodiazepine full time, and to get me through this acute phase of pain and discomfort. And so I did. She wrote for 1.5 milligrams of Xanax to be taken every day. And she also started me on Neurontin and suggested I start with 600 milligrams and work my way up to 1,800 milligrams a day. And my gynecologist had an idea of prescribing a vaginally applied suppository of Valium, so it would relax the pelvic spasms I was having. So I left with these prescriptions and began that schedule, but I was so heavily sedated on this amount of medication, I went right back down to about half of the prescribed doses of all 3 medications. And the pain subsided a little bit. I was able to be more functional. I was less anxious. I was sleeping better, but only for a short time. And in about a month's time, the anxiety came back in a very, very severe way. The panic did. In this time, it was accompanied with deep depression and something I had never experienced before, suicidal ideation. And this was devastating. I was no longer able to work at this point. I had to take a medical leave, and eventually I had to retire, take an early retirement. My husband, Bernie, was a full-time caregiver. It was so difficult. It was just so very difficult. So the symptoms, I went back to my physician with these symptoms, and I said that I was concerned that the medication schedule was actually contributing to the way I was feeling, that the anxiety and panic had come back with such vengeance. Was there a possibility that it could be related to the medications? And she did not believe it was related to the medication at all, and was not supportive of that theory. And so I left, and I didn't go back. I didn't go back to that physician. I had to find somebody who would listen and somebody who would take my concerns seriously. So I went home, and Bernie and I put our heads together, and we knew that we had to find a different route out of this. And early in my career, I had worked as a research nurse at OHSU in Oregon. And on days that I felt better, I could put those skills to use, and I started looking for answers. I was on the computer as much as I possibly could be in the fragile state I was in. And I want to go back to the symptoms. Along with all of the mental health symptoms I described to you, I was also having widespread body pain and a lot of other debilitating issues. So one of the things I found online was the Ashton Manual by Dr. Heather Ashton out of England. And Dr. Ashton had worked predominantly with a benzodiazepine, as a benzodiazepine expert in helping people taper off of these medications and recover from the effects. And when I read her works and everything I could find that she had published, and I looked for other literature on benzodiazepines, I found what I needed. I found the information that supported the way I was feeling, that the symptoms I was having were directly related to the effects of these drugs. So I had grown dependent taking them intermittently, or grown sensitized taking them intermittently. And now that I was taking them full time, I was having a dramatic result. So also online, I found support groups of people just like me, accidental dependents, people who had taken this medication as directed and become very ill and were now struggling to taper off and recover from their devastating effects. So I was not alone. So I knew I needed local support. I couldn't go back to the other physician. I felt so unheard and disbelieved. I needed to find another. So symptoms to help me manage them. And I had also seen one of her practice partners, an osteopath, and Wendy agreed to continue to see me, as did my naturopath. So I had some people on board. And then I was lucky to find in our community another naturopath who specialized in mental health. And she had a lot of practice tapering people off of. I had a massage therapist and an acupuncturist and my pharmacist at Lloyd Center Pharmacy. Thank God for them. They knew how to do this. And I found another MD too, and because I needed someone to act as my PCP. And when I went to see him and told him my story, he said, first of all, I believe you. And second, how can I help support you through the rest of your journey? And those were the words I needed to hear. I needed to know that someone believed me. And I think this is important to say that none of the people I was seeing, aside from maybe my pharmacist, were experts in the fields of benzodiazepines. None of them were. But they were curious, and they were interested in my case, and they really wanted to help me. They became my advocates, and they read the Ashton Manual. They did their own research. They were just what I needed. It really takes a multidisciplinary approach to get somebody through this, and I owe my success to them and to my family. So I had to taper. So I started with the Xanax, shorter half-life, and I practiced cut and hold. I would take a little slice off the tablet and waste it, take the tablet, and monitor my symptoms. And if my symptoms increased, I slowed down the taper. It was a long, long process. And Dr. Ashton documented 90 symptoms that people exhibit coming off of, or after exposure to benzodiazepines and tapering from this medication. I had all but 2. I was very, very sick. There wasn't a body system untouched. So when I started this taper, my goal was to remain as functional as I could possibly be. I wanted to be able to take care of myself, because there was a time there that I needed assistance with bathing and everything, cooking. I could not do any self-care, and my dear husband stepped in to help me with that. So I wanted to care for myself. I wanted to keep these hideous mental health symptoms at bay. I wanted to feel safe, because fear is a big component of this. And I wanted to feel like a mom and a wife and a friend again, because that had been robbed. So I never felt well during the taper. I just felt less sick. So I mentioned the body systems. There wasn't a body system untouched. Man, that's so very true. Just a few things I want to mention. Myalgia, just very acute. Stiffness, muscle spasms, neuralgia, numbness, nausea, anorexia. I had frequent urination or inability to tell when I had to void. I had to put myself on a toileting schedule so I would keep my bladder emptied because I could not feel. I had this random numbness all throughout my body, numbness, burning, tingling. And I had sensitivity to all forms of neural input, like auditory. We still eat with plastic silverware at our house because the sound of metal on china was more than I could bear. It was so painful to hear that. So one day we'll change to metal silverware again, Bernie, I hope. And any tactile stimulation, I had to wear yoga pants and loose t-shirts. I couldn't stand anything tight on my body. And then visual stimulation. This was a big one. Riding in the car, and I had to have a chauffeur always. Bernie drove me everywhere because I, of course, couldn't safely drive. And riding in the car, I had to wear a mask, a sleep mask, earplugs, and we had to stop often because the vibration of the car was so painful. I couldn't tolerate it for long periods of time. That was very challenging. It took me a total of 38 months to heal off of 0.75 milligrams of Xanax and 2.5 milligrams of Valium. That's astounding. That's over 3 years of my life devoted to that. And it's widely believed that once the drug is cleared from your body, that you'll start feeling better. And that may be true for some people, but for me it wasn't. It's not about the level of drug in your system. It's about the damage that the drug has caused. And so, once the taper was complete, I thought I would start feeling better right away, but I really didn't. The symptoms continued, but at a much lower level. I was able to engage more in life, but some days were still really, really hard. I spent a lot of time in bed, a lot of time on the couch, and a lot of time walking my dog. So today, I'm 4 years, 2 months off of these medications, and I am still pretty profoundly affected. I am much, much better, but I'm not well. And I haven't felt well since this all began. So I would not have been able to do this 2 years ago when we had the TIBS conference. I couldn't speak. I couldn't coordinate my thoughts. I had trouble with all the stimulation, and so today I'm here, and this is such a sign of progress, and so I'm so grateful for that. I want to mention the lovely speakers who will be following me, because at some point in the past, they have all heard little bits of my story, and all of them were curious and interested, just like the medical team I found for myself in my hometown of Portland. And they took that curiosity and interest to the next level, and then the next level, and then the next. And here we are today. This is monumental. So I thank all of you for listening and believing my story. And for all of you that are here today, I just thank you so much for taking the time out of your busy days to listen to this, because again, I am one voice in a very large community of people who have been damaged by this medication. And if we're heard, change will start to happen. And I hope that my story will shed a different light on the way that you all see benzodiazepines. And that different attitude will lead to some change, prescriptive changes, and also just general knowledge change and behavior around these meds. So I also want to thank Christy and Sonia, two of my online friends who were going to be with us today. And Dr. Roffa mentioned that both of them were just too ill to make the trip. And both of them have been off of benzodiazepines for a while. But this can take time for some people. And not everybody will have this profound a response to exposure to this medication, but enough people do that we need to start listening. So lastly, I want to thank my husband who has, and I saved this for last because I knew it would make me teary, who has been with me every step of the way. Yeah. So, thank you.
Wow. So that's just one of the many stories that we heard. And it goes beyond that. So I'm a basic scientist, pharmacologist. And at this meeting in Bend, I thought I was going to talk about what I always talk about, how the benzodiazepines work. And the patients began asking me questions like, well, Dr. Roffa, do you think maybe it's the benzodiazepine receptor that's up or down regulated with chronic use, or some subsection of the GABA A receptor, or some second messenger down? I'm like, whoa. They have really thought about this, and I said, I better go back and look into this further. After you hear stories like this over and over and over again, you begin to believe there's something there. And again, as Carrie said, not everybody, but a subset of patients. And I think it makes sense, right? No drug is perfect, so it might be true. Let me look into the basic science and see what I can find. So that's, in this, I just want to give you a sampling of some of the things I learned in looking into this. And I'll talk a little bit about we know about the benzodiazepines and how they work as anxiolytics. And then what I like to do is introduce to you a different way that I began to look at this and began to think differently about them. So in the way of disclosure, I worked for Johnson & Johnson in drug discovery, but in no way anything related to benzodiazepines. I continue to stay active, but I have absolutely no financial or any other interest in either the use of benzodiazepines or the non-use of benzodiazepines or anything else. This is just what I've learned in looking into this. So again, as Carrie said and others have said, we're not here to in any way trash benzodiazepines. I think it's probably fair to say they were life-saving drugs in the day. They displaced drugs that had way more problems, and they continue to work well for people, or most people. And we know a lot about them for up to 4 weeks. Beyond that, this is why we're here today. So, what is the basic science of the benzodiazepines? And I think the conclusion I reach is that it depends. There is a Dr. Wright who's going to talk to us a little later. There's wrong. And then there's something in between. So, what we know about the benzodiazepines, we know very well. We know extremely well. So if you were to ask me or Dr. Vanderah or any of the other pharmacologists here, we would be able to give you in great detail how these drugs work as anxiolytics. And we've known that for many years now, that the action obviously is on the brain, and that it involves a GABA-A receptor complex, which we know a great deal about. We could even talk about this molecular formation of the receptors, all the different little packets, and how they're arranged in three-dimensional space, either looking at them sort of crosswise or down from the top. We know that it involves the amino acid GABA, and we also know that the benzodiazepine molecules interact with the same GABA-A receptor complex. So as shown here, unfortunately I don't have a pointer that works on that screen, but you'll see there where the GABA, naturally occurring amino acid, which tends to protect us from overexcitation, so we don't have seizures all the time. It's an inhibitory amino acid. Interacts with the GABA-A receptor at a certain special place. Benzodiazepines interact with the same receptor, but at a different site. But what benzodiazepines do is they tend to magnify the effect, the inhibitory effect of GABA. I know that's very nice of you, but it just doesn't show up on the screen. But so what the benzodiazepines do is sort of enhance the action of GABA. So before, where your neurons would respond to some sort of excitatory impulse, now with the benzodiazepines, not as much. So the benzodiazepines don't turn the neurons off by any means. That would not be good. But you just tend not to respond with the same excitation as you would otherwise, which is ideal for somebody with anxiety. And we know exactly how that works. It has to do with modifying the influx or the transmembrane influx of chloride ion. And it hyperpolarizes the neurons and other. I mean, it's a beautiful story. We know all about it. Now, what we don't know so well is what goes on beyond 4 weeks, because I know it's hard to believe, but it just hasn't been studied that much, because these drugs go back many, many decades. And guess what? They were effective and they were safe. So the duration of treatment, it's natural, right? You just say, okay, 2 weeks, yeah, why don't you go another week? Why don't you go another week? You know what? Everything's working well, why don't you go another week? So it's natural. We're not placing blame. But certainly when you give a drug beyond 4 weeks, there's going to be changes in the receptors. The body is just not going to respond the same way as it did on day one. So there's no question there's down and up regulation of these GABA receptors and the benzodiazepine receptors. Their numbers are physically changing. The body is adapting to what you're doing to it. Functionally, they're changing as well. This has been proven over and over again by electrophysiological studies, chloride, very precise, sophisticated studies. So there's no question that the patient who's been on benzodiazepines for more than 4 weeks, their body is just not the same as it was when you initiated therapy. There's also, and this is startling for those of you who are not basic pharmacologists, what we do is we look for what other receptors do these drugs bind to, and once we have that table of information, we can begin to predict what these drugs do or explain how they work. Nothing. These drugs are so old that it was not typical that they had what we would now call broad screening. So I could tell you, I should have prepared a table. I could tell you exquisitely how these drugs bind to the benzodiazepine receptors. Every other receptor would be totally blank. So we just don't know. It was never thought to be necessary to do it. So we're flying in the dark, and so for a basic pharmacologist, I don't even know where to begin. That's like pharmacology 101. So we certainly know the left-hand side of the screen there. We know how it works as an anxiolytic. We don't know any of these other effects, which we call off-target effects. So then I began to look into it, and I said, well, what is out there? Turns out that benzodiazepines potentiate adenosine A2A receptor-mediated effects. Do you know what that means? I don't know either. Benzodiazepines allosterically modulate alpha-1 adrenoceptors. I do know what that means. They're on blood vessels. So what do you mean? Benzodiazepines are affecting blood vessels? Maybe something to do with the cardiovascular system? Geez, where did I hear that before? Maybe from the patients. I never heard this in my class, and I certainly never transmitted this to all thousands of students. Benzodiazepines possibly are agonists at oxytocin receptors, so now we're involving the hormonal system, and I'm hearing the patients even louder. So as a result of really trying very, very hard, do you remember the movie Billy Madison? So Billy Madison so on the left there, the person asks him a question. Billy Madison gives this long, crazy answer. And the moderator says to him, everyone in this room is now dumber for having listened to you. And that's exactly how I felt after putting in all this time and effort trying to figure out what these benzodiazepines are doing. I felt the more I was looking into it, the dumber I was getting. And I came to agree with Alice. It would be nice if something made sense for a change. So I said it's time to change the way I look at this. Instead of starting with these drugs relieve anxiety, how do they work? I said, let me step back. Let's imagine a patient that I'm giving a benzodiazepine to and ask what happens to them. So clearly the benzodiazepines go up into the brain and they relieve anxiety. Then I found this paper, and this is a scan of benzodiazepine binding not to the brain, but the rest of the body. And I was just stunned. Mostly these types of scans, there's a little bit of a light here, a little bit of a light there, and you try to figure out what it is. The whole body is lit up here. So how could that be? Well, we didn't know this because the people who studies it have a different name for these receptors. But they're really peripheral benzodiazepine receptors, and that's the name we're going to be calling them by now. And what's lit up there? Mitochondria, right? The cell's energy supply. So, geez, what would somebody look like who is having problems with their mitochondria? Maybe they wouldn't have a lot of energy. And every patient would be different. It would depend on the time of day. It would depend on your level of exercise. It would depend on all these things that the patients are telling us. Would any two patients have the exact same symptoms? No. Where else are those peripheral benzodiazepine receptors? They're on immune cells. So what would the patients look like? Maybe a few more colds in the year, or this, that, or the other thing. So it suddenly reminded me of lupus, where two people could have lupus and not share a single symptom. So it could be something. So now I was very intrigued, and I said, well, what else could be going on? Well, I'm not here to tell you the answer because I don't know the answer. And maybe that's my fundamental message, and that's the message that maybe the FDA has to hear. We don't know. I looked real hard, and I don't know, and other people aren't even looking. So what would just be logical? Well, there'd be changes in, polymorphisms, everybody's individual genetics, either in terms of receptors or metabolism. I mean, this again is just pharmacology 101. What about protein synthesis in either direction? Epigenetic changes, right? We all know that that's very important. So just one's environment is going to make a big difference. What about nutritional factors? Never ever been looked at, but actually the whole issue of nutrition and GABA-A receptors and benzodiazepines was looked at many, many years ago right here at the University of Arizona. Professor Hank Yamamura, famous pharmacologist, and he actually began to question some of these things many, many years ago. No one has really followed up on that. And then there's even a theory, a biochemical theory. Pretty complex, but it, could make sense. But anyway, what I'm trying to say is, all these things are probably going on, and we just don't know. And so I wish I could tell you the answer to this, but I can tell you this, that for 2 to 4 weeks, if you're asking just about anxiety, and we're going to hear in a minute about the question of pain and muscle relaxation, we know a fair amount. And probably things are okay. But I can tell you this, there are now better drugs for almost every one of these conditions. What about 2 to 4 months? We don't know much at all, and it just hasn't been studied. 2 to 4 years, we know nothing. And these poor patients, it's one thing to say they were guinea pigs, they were put on these drugs for 2 to 4 years. Here's the real sad part. Nobody followed the experiment. The guinea pigs were allowed to go on. Nobody was collecting data. Nobody was taking notes. And nobody was keeping track. So with that, I think Alice, I recognize a pharmacologist in Alice. It was all very well to say, drink me, take these medications, but the wise little Alice was not going to do it in a hurry. Now, I'll look first, she said, and see whether it's marked poison or not. So with that, I would like to thank you again and introduce our next speaker, Dr. Joseph Pergolizzi, no kidding, one of the world's premier pain experts, clinician, clinical researcher. He consults not only with all the analgesic companies, the FDA even asked him to consult. And so he'd like to talk to you a little bit about today, in which the benzodiazepines have unfortunately gotten the reputation of being pain relievers and muscle relaxants, and he'll explain a little bit about that. Joe? And by the way, I should, thank you, I should mention we're going to reserve a lot of time this afternoon for questions and answers, and we're going to all stay around and be here for that.
Thank you very much, Bob. Thank you, everybody. Those physically here and those at a distance. Let me just pull my slides up. And so this is water, right? I come from Naples, Florida now. I transitioned after retiring from Johns Hopkins University School of Medicine after being affiliated for 21 years, and I moved down to Naples, Florida. And this is the title of my lecture. And, it feeds off that Alice in Wonderland pathway. So I'd like you to step back for a second and just analyze what we've heard. A patient who is a medical professional that had these type of symptoms, that had to go outside traditional allopathic, even osteopathic training to find an answer, and then had to bring a team back together. That's not easy. Everyone likes to talk about multimodal, that's pharmacological and non-pharmacological. Multidisciplinary, that's lots of different disciplinaries together. Multi-mechanistic, multi, but it's not easy even as a practitioner. And a lot of credit goes to Carrie and her husband, Bernie, to be able to achieve that from a patient level. And I think that's the exciting part and what brought me to want to be involved. So living in Naples, Florida, we deal with older people who go to take care of their parents, right? And it's a little bit of a different lifestyle than here in Tucson. And these are my disclosures. I work with lots of different companies all over the world, and federal and government institutions as well. These are the objectives of my lecture, and I'm going to make it short so that we can hear more from Steve, because he's asked me to do that. And the truth is that it's somewhat of an information explosion from the creativity side, because we don't have a lot of evidence-based information. So it's quite anecdotal, and that allows you to be very creative. And creativity is wonderful, but you have to make it actionable, and that's innovation. And that's the call out to everybody today, is with the little tidbits of information that we're going to go through, how can you become creative and then set that into action so that we can address this unmet need. And so it usually starts off with really understanding what you're doing and being able to explain it at a very simple level. But if you don't have that basic fundamental information to draw on, then you're limited. So what do? Well, we call a bunch of experts together, like here, a lot of interested individuals. And sometimes those interested individuals come together and they can even put a man on the moon, right? Sometimes we just sit around and contemplate in other ways and think about how we may be able to achieve that. And sometimes we call out the cowboys to come try to rescue us when we're failing and we're trying to really achieve excellence. So what happens when you have a position that's not very well grounded in evidence, it's more anecdotal? Well, you get a lot of pushback. And I would assume as we go to develop a pathway forward to answer what's happening to people like Carrie and the effects on their family, which go beyond the physical realm. They're metaphysical, right? When suffering happens because of the inability to address appropriately a patient's disease and manifestation, that's a metaphysical consequence. And William Osler said that good doctors treat disease. Great doctors treat patients. So that's what we have to do, and even more so, people. So how do we do that when we're left with this big void? What do we look for? Well, we start to rethink our theories, and that's what Bob and I are trying to do at a grassroots level, at a state level, a national level, even globally. And it's important we change. You heard the word change a couple different times. That's something that we must do. And we have to design and find out what exactly is driving it. Because guess what? These patients are actually in your office. Like when I met with Carrie, I felt as a tertiary care physician, with all those wonderful accolades that Bob and my mom talk about, how did I miss this? What happened? Why wasn't I looking? I need to learn more. But there are rules, right? It's very important that we fundamentally understand the science, because if not, you get penalized, right? So we don't want that. So we know basically that most of our science was focused on the brain, right? Because that made sense. Now, Bob just showed you some cutting-edge research, and more is being done here by Todd and his group, which we're really happy to be involved with, that says, wait, these receptors may be somewhere else. And when you start to think about that, it adds a whole level of complexity. And that complexity then should really ignite creativity amongst researchers. And all the young researchers in the room, like you saw Charlie Wolmuth. Charlie is from Tufts University, and he's a Beckman Scholar. We brought him into this because he's the best of the best, and young, and not tainted maybe with some of our views, right? Because we have to find a better way. We have to find a better way because guess what? There's a lot of people out there that are probably experiencing some form of this, because there's a tremendous lot of prescriptions that are happening. And when we look at the areas that I have interest in, what we find is that pain and anxiety have a very high comorbid index. And it's not uncommon that patients who have pain experience anxiety or depression, and even to the clinical standpoint of that. So, as you heard with Carrie, benzodiazepines have been looked at as muscle relaxants by some individuals, and still are prescribed as that, even though there is no scientific evidence to support that. Now, maybe some of the psychometric properties of benzodiazepines can transliterate over into a perception of analgesia, but it's not a true analgesic. But there are a lot of other different myths that are out there as well. Bob touched on one of those and explained that this idea of going beyond 4 weeks, not such one proven in the literature. How about the idea that happened to Carrie, where we went from a long-acting to a short-acting? Makes sense, right? Not really supported in the literature. So a lot of things that actually happen to you are what's in the literature. That's a problem. That's an Aristotelian metaphysical problem. It's called fallacy of the illicit major. That's a real problem. That means every idea you have after that is wrong. So you got to sort of clean the board and start all over again. So where do you start? Well, you look at what's out there. And then you also look at what's being developed, because you wouldn't want to have the same thing happen twice, right? So you want to say, well, what are other people doing, and is it a similar type of drug, and why aren't we looking at that, and why shouldn't we? And guess what? There's a lot to look at, because a lot of people in the United States are being prescribed these agents. Population pyramid's upside down. Benzodiazepines are commonly prescribed to older patients, whether they're on a Beers list or not, whether or not they're being prescribed appropriately, but it's not uncommon that older patients have issues sleeping. So when they burn through a lot of natural products, they wind up on benzodiazepines or Z drugs. And you know what? There's even a bigger paucity in data when it comes to special populations in benzodiazepines. And this just shows you some of the highlights related to elderly patients. But there's not enough. So any of the younger researchers that are out there, this should be something you want to jump on and make a name for yourself, because it's wide open. And where's one of the bigger concerns? Well, look at this, overdose in the United States. You're going to see some big news tomorrow about another pharmaceutical company related to opioid overdose and deaths, right? Look at number 4. It's held number 4 for the last 9 years. It's a benzodiazepine, right? It's not an opioid. Notice there's a lot of movement between 2010 and 14. And if I showed you 2016 numbers, the same thing, but the only one that's held steady is number 4, right? And we see that more and more people are winding up in emergency rooms because of polysubstance overdose. Here in Tucson, it represents about 40% of your drug overdoses, right? And that can lead to a big problem, particularly if you're trying to rescue someone with a opioid antagonist, right? And it's a polysubstance overdose that has a benzodiazepine. You're not going to do much. So, you know, this has led to a lot of concern by the FDA and the CDCs and others. And when you look at the warnings and precautions for opioid therapy, they talk about concomitant, clinically relevant, pharmacodynamic, and pharmacokinetic drug-drug interactions with CNS depressants. So agents like an opioid in combination with a benzodiazepine have some potentially pretty profound pharmacodynamic drug-drug interactions that can lead to apnea and death. And that's why you see this in the boxed warnings for heightened awareness for patients, caregivers, and prescribers. And these boxed warnings really carry all the way through when it comes to patients who are on opioid or opioid substitution therapy as well. So the big picture then is to try to come up with better basic science and to use that translational medicine as quick as possible in the clinic, because this is real time, it's happening. It's not like these drugs are waiting to be approved. So what do we do? Well, maybe look at who's at more risk. We don't really know that. We're not sure who's at a higher risk. And even if we did have a risk protection tool, what would that really do for us, right? From a practical standpoint. So how about learning some lessons from the opioids, right? And I think what we can learn there is that we need broader education. We need to involve all the stakeholders. This is a call to action, right? And we need to use the KISS principle. If we over-engineer it, all due respect to Bob, my engineering friend, I could say that because I was a physical chemist before I was a doctor. So if we over-engineer it, we may not get the results we want. We may get this, you know? No one's looking to bastardize this class of drugs. We're just looking to better understand what we're doing. There may even be better benefits there. There may be things that we find out now that are even more important. And we know right now there's no one golden bullet to help with some of the reasons why we prescribe these compounds, whether it's on-label or off-label. But we do know certain patients do benefit from it. But we have to be aware cause and effect. There are those who don't. And it's probably upon us to do no harm and to understand what we're doing. So we need to have research at the basic science level. I applaud the University of Arizona and Bernie and Carrie to give that opportunity here, and we are making groundbreaking research. We need clinical science. We need some real practical knowledge out there, and we need to make this a societal message. Believe it or not, there are different types of databases that are available that you can access to start generating information. Unfortunately, they're not very well frequented. And even more so when we look at someone like Carrie and we try to define, well, what's the nomenclature here? How do we write this down in someone's chart so that someone else can follow up and do better? And we're not even in agreeing on the taxonomy of this, right? I like to sort of call it prolonged withdrawal syndrome or protracted benzodiazepine syndrome, withdrawal syndrome. There is information out there for providers that you could start looking at. You could start socializing. For patients, the same thing. It's out there, just not very well socialized or uptaken. Take-home message, we want to be very judicious until we know more, right? We want to try to err on the side of safety. And if you are thinking about discontinuing benzodiazepines in your patients, well, it should be a shared decision-making process, and we should have some expectations about what our patients and what our team can do and try to achieve, and how long that might take, and what we might need to do in order to achieve a positive outcome. So in summary, benzodiazepines, right now, we need to know more in order to better prescribe them. We need to understand that, particularly when we're prescribing with other CNS depressants or opioids, this could be problematic, and listen to the FDA and the CDC. More research is needed on all levels that I just showed you, and the stakeholders really should take this as a call to action from the opioid crisis in the United States and try to make proper modifications. And it's not that easy, right? But it starts with interested individuals like us, and that's how the message gets out. And I think we will be able to get, within the next year, certainly an increase in our baseline understanding of what's going on from Todd and the rest of the individuals doing some basic science. And I can tell you that from the standpoint of the other stakeholders, I intend to call in some cards. Because if we don't, we're not going to get where we need to be. And that is to better define these agents and to provide a safer paradigm for our patients when they are being used. So with that, I thank all of you. I encourage you all to think about researching this and getting more involved, and I invite you down to Naples, Florida to come play golf with me. All right? Thank you very much. And I'm going to now invite the Wright doctor up. That's Steve Wright. Steve's a very impressive individual. He's got a great command of clinical knowledge when it comes to what Carrie is suffering from, and other individuals around the United States and maybe even around the world. So it's a pleasure to share the podium with Steve, and I thank him very much. Thanks, Steve.
Thank you.
Hi, my name is Steve, and I'm a recovering benzodiazepine overprescriber. Come on, guys, you know what the deal is, right? Let's try one more time. So, hi, my name is Steve, and I'm a recovering benzodiazepine overprescriber. Thank you, thank you. It all started out very innocently in the Midwest, strong codependency features, genetically determined, environmentally enhanced, and I refined it to a fine art, over a long period of time. But I had a lot to learn. I grew up in family medicine in my family. Went into medical school at Case Western and did the whole thing, free clinics, this, that, and the other. Wanted to help my patients and wanted to help them with what we learned best in a lot of different ways, which was to provide medications in the right circumstances. But I had a lot to learn. There's so many things that have shifted over my career, over time, among which it includes the idea that no is a complete sentence. We end up with what we're doing and find ourselves off-center a lot of times because indeed, it is not a commercial operation that what we're involved with. It's not like I go in, I want the blue shirt. If I have money, I get the blue shirt. But so much of the time, the ask of patients sometimes drives us to make choices as well without putting our judgment into play. What we're really doing in this enterprise is actually we are asked and paid for our opinion, not necessarily a product. And what happens, of course, is that substances end up being involved, right? Caffeine, we start our day with this, end it sometimes with something else, and then we are involved with our patients where we sprinkle in a variety of medications here and end up sometimes with this, with whole households and whole individuals that are supported in this particular way. Osler said, the desire to take medicine, perhaps the greatest feature which distinguishes us from animals. And there's something to that. And then we can end up with something like this. And it's very difficult to know, for example, is this the primary disease process that we are trying to assist, or is this the outcome of the interventions that we've been involved with? So I'm Steve Wright. I grew up in family medicine, as I mentioned, family medicine residency in 1982. I've been doing addiction medicine for 32 years and medical pain management for the last 15 years. So I got to be part of the problem as well as hopefully part of the solution. I love the neurophysiology of all of this, not that I'm an expert, but the neurophysiology, because this tells us why we do what we do as human beings. Absolutely fascinating to me. I'm the kind of person that wakes up in the middle of the night thinking, what's the anterior insula of the brain saying to the posterior insula of the brain? I know, Bob, you wake up that way too. I know your voices talk to my voices as well. But my daughter, who is 30 now, came up to my wife when she was 7 and said, Mommy, is Daddy a nerd? And she said, yes, and we have to deal with that, and you have to deal with me. So these are my disclosures, a variety of different companies, and I can tell you that, with regards to the pharmaceutical industry, absolutely there are problems associated with this. But those of us that are speaking and those of us that go to advisory boards and that sort of thing, it is not just bobbing our heads and agreeing to whatever is going on. We absolutely challenge what's going on. At a conference a couple weeks ago, the words came out of my mouth, irresponsible, on a couple occasions with discussion with pharmaceutical industry. Now, that being said, some of the best education that I've ever had has been through the pharmaceutical industry as well. And so there's a balance in that regard. And we need to ask the questions as to what is going on, and indeed, is this actually true as well? And I really want to give the nod to the Alliance for Benzodiazepine Best Practices, Carrie and Bernie Silvernail as well. This ship got launched, as was mentioned, in 2017 with the conference in Bend, where I was engaged in that particular process as well. Marjorie Merritt Carmen launched the ship with a lot of others. We put this together, and it has been nothing like what I thought it was going to end up being. I was one of those people saying, benzodiazepines, old, boring, uninteresting. Certainly, we know all the answers in relation to that. That certainly has not turned out to be the case. So we want to talk today about the risks, the benefits, the alternatives to benzodiazepine receptor agonist use, in particular about withdrawal, and then land on some recommendations as well. And the story very typically begins with anxiety, and this classic painting by Edvard Munch just depicts the kind of distress and anxiety. And those of us in clinical practice, we want to do something about this. We want to help our patients get better in that regard. And so we have a med for that. In 1950s, Leo Sternbach had a whole bunch of benzodiazepines driving his research assistants crazy in terms of evaluating these, and found anxiolysis in animal studies Very quickly thereafter, in 1960, it was introduced to clinical use, and soon thereafter, just in a single year, Leo Hollister identified very severe withdrawal among individuals using chlorodiazepoxide, the very first benzodiazepine. Sternbach was also involved in introducing diazepam in 1963, and then from 1968 to 1981, the number one drug prescribed of any type, any class, anywhere across the United States and the Western market. Problems started to develop. And there was a recognition of the potential for addiction associated with that, and so the FDA scheduled this, Schedule 4, in 1975, where it remains today as well. In 1979, the Kennedy hearings, the congressional hearings, a very large document was produced, a lot of testimony by individuals that were severely affected by this, and nothing happened. But we had a lot of data along the way. Probably the best early review, Malcolm Lader put together the indications, the risks, the benefits, and all of that in 1983. A lot of that really stands today, and it's just it's something that if we take a look at, we can understand this whole circumstance a lot better and recognize that indeed we are not following the kind of direction that the early researchers often provided to us in terms of the warnings and the harms that could be out there. Certainly represented an advance over the barbiturates and meprobamate. Don't want to give that short shrift as well, but we need to advance from there as well. In 1991, the Beers List, you're probably familiar with this, the list of medications that are of particular concern among the elderly. Now, that being said, I'm not particularly a fan of the Beers List. You go in there to look for opioids, which I think should have a large display within the Beers List, you don't find much. You find tramadol, you find meperidine or Demerol, but you don't find the other opioids. And so I'm not sure how this ends up being constructed, but nonetheless, the benzodiazepines have been on that list, appropriately so for a long period of time. And then the Ashton Manual, which is the Bible for all of us that are involved in this particular process, and certainly for the patients that are out there as well. And here they are. These are the lists of available benzodiazepines, 14 of them in the United States. There are many others throughout the world, and a lot more sitting out there that could potentially join in. And then the Z drugs. Z because that's in the name of most of these agents. Zolpidem, Zaloplan, Zopiclone is no longer available in the United States, but these are primarily used for insomnia. But we also know that they have serious side effects as well, sedative side effects, amnestic side effects. We hear about sleepwalking, sleep driving, sleep sex, go figure, and it is a very big deal as well in that regard too, but it's not the number one recommended choice as well. Cognitive behavioral therapy for insomnia, CBTI, has been out for a long time, is really first line in that regard. And together, we recognize these agents as BZRAs, or Basra's benzodiazepine receptor agonists. Included in that mix, incidentally, are a lot of the anesthetics like propofol, and alcohol has an effect as well. So there are profound implications for all of these kind of things. So how about our use characteristics? Prevalence is really significant. In the United States, 7%. This has nearly doubled since 2003. And therefore a big deal. So we saw that diazepam was the number one prescribed drug of any type back in the 1960s through 81, but now it seems to be a resurgence of that as well. In Canada, 4%, depending on where you are in Europe, 4 to 16%. And there are a number of factors that are associated with prescribing. Of course, it goes without saying in terms of anxiety and insomnia, but also in the pain domain where there's not associated mood disorder that's well identified, chronic medical conditions in general, being female, white, in retirement, low income, being elderly in particular. We see a lot of studies that kind of settle in on about a third of elderly have had a benzodiazepine in the previous year. Smoking, poor health, more than one prescriber. And when we make it easier to prescribe, such as with computer prescribing, there is an associated increase in use as well. Coming from addiction medicine, I have a lot of interest in relation to the non-medical use of a variety of medications, including the benzodiazepines. Now, non-medical use just means basically use for a reason other than what is prescribed. And so an opioid, medical use, for whatever pain condition, non-medical use to get high or have euphoria, to avoid addiction, or to avoid withdrawal, things like that. For benzodiazepines or the Bosras, the non-medical use rate, in the best numbers that I can find, about 1 to 2% of our population is involved in that way. That is not the same thing as addiction. We certainly see a lot more of that in college age and high school youth in particular. But what about the disease of addiction? Now, the disease of addiction is very specifically defined, and the first definition of this came from David Smith in 1984 in a cocaine article. And it stands true even today, and that is compulsion, thinking about it all day long, loss of control. Today I'm going to have 2, and then I actually take 20. Continuation in spite of adverse consequences. I get loaded, I plow my car into the tree, I swear I won't do it again, and then I do. Or I come off a roof, or something like that. That is the disease of addiction. And in terms of the studies that take a look at that, 8 to 10% of those that are using non-medically may have the disease of addiction, but even that is somewhat questionable. And the reason is, when you look at the DSM-5 criteria, there are 11. You only have to have 2 of the 11 associated with that, and you look specifically at the one where where it indicates the individual is having difficulties with attempting to discontinue or taper down and having difficulty with that. That sounds like the individuals that are on benzodiazepines that we hear about struggling all the time, but you have to look at the background to that, because the individuals with addiction, they are craving this, and the individuals with benzodiazepine-related problems rarely crave. The disease of addiction is quite rare even in addiction circles. Over my career, I think I've seen exactly 1 person with the disease of benzodiazepine addiction. This was an individual who he and his girlfriend were trying to work this out. We were trying to work out a taper. He had a lockbox, and it kept disappearing, the Klonopin, that taper that I was providing to him. Well, he was tapping out the nail in the back to open up the backside of this locked box and taking it out. Now, that's the disease of addiction, where you're driven to using something. But individuals that are challenged by benzodiazepines very typically are not in that circumstance. The vast majority of them do not increase their dose, do not ask for dosing increases. And therefore, we in addiction just kind of lost sight of this being particularly important as well, but it is indeed quite important. Nonetheless, addiction liability is present. And different agents have different addiction liability, alprazolam in particular, diazepam as well. Most of the time, individuals using Bosras are doing so, the benzodiazepines, for other purposes, to augment other addiction substances, for example, alcohol or opioids. It'll pump up the effect, or to ameliorate offset the negative effects of discontinuation, the withdrawal effects as well. And it's really important to recognize that the vast majority of benzodiazepine survivors, as they are called, are related to physiologic dependence. It is not indeed related to addiction. And that becomes a significant challenge in identifying the appropriate course for these individuals. In pain management, 1 out of 5 patients who are on opioids are also on benzodiazepines, not necessarily for a bona fide reason as well. So the number is actually about 17%. And the risks associated with co-prescribing are quite significant. There's a doubling of emergency room visits and hospitalizations due to that. And they're involved now in somewhere between 50 and 80% of opioid-related overdose deaths. It used to be in 1999, about 19% of overdose deaths had included a benzodiazepine. 2013, the number was 31%. We are now up to 52% according to a CDC study that took a look at this. Interestingly enough, Mattson et al. Developed those particular numbers out of 11 states where that data is available, because indeed that data is not necessarily available to us in all of the states. But it's about 52%, and actually Dasgupta et al. Took a look at this in North Carolina, and that number was 80%. So it's a very significant problem. What is the evidence in relation to use for pain characteristics? It's not there, as Joe mentioned. For spine pain, the reviews are mostly unfavorable. It's ineffective for radiculopathy. For centralized pains, there's some theoretical ideas that it might be useful, but the data is really insufficient. There is a little bit of data in relation to multiple sclerosis. There's more data associated with burning mouth syndrome, but of all the pain domains that are out there, I cannot find literature to support the use of benzodiazepines in other contexts. But we certainly have this, and that is the overdose deaths related to benzodiazepines with and without opioids going up over a period of time that's very, very concerning to all of us. So we land on anxiety, and Mark Twain said, "I've had a great many troubles in my life, most of which never happened." This is the so-called transient or state anxiety, the kind of thing that's going to go away, the kind of thing that we don't necessarily have to treat, but very often those of us in primary care or psychiatry may be treating with benzodiazepines. It's useful to look at a taxonomy in relation to all of this. Anxiety is that feeling that's related to an anticipated threat. And for this purpose, fear is the feeling related to an immediate threat. It's right out in front of me. The lion is attacking, that kind of a thing. The stressor, the events, the worry are those thoughts. Stress responses are the physical responses. And then we have the anxiety disorders in and of themselves. And there's several of them. This is the trait as opposed to state anxiety. And anxiety disorders, they are defined by anxiety extending over a 6-month or longer period of time, functionally impairing, and circumstances in which the anxiety exceeds the expectation related to a threat. So, for example, getting up and speaking, nobody's going to hurt me out there, but one might have a lot of panic about doing something like that. In that circumstance, the anxiety exceeds the actual threat that's involved. That's what an anxiety disorder is, and it very much gets conflated with normal anxiety that does not need to be treated by benzodiazepines, or for that matter, a lot of other agents that we often select. Anxiety also occurs in other mood states as well. We have the trauma and stressor-related disorders like PTSD, and anxiety and obsessive-compulsive related disorders. These were recategorized. They used to sit as anxiety disorders, but now, because their core symptoms were felt to be significantly enough different, that they sit all by themselves and indeed respond uniquely different when we look at anxiety related use of benzodiazepines. And then, of course, in other medical conditions. So if we have a problem here, why not just kind of pull up our bootstraps and deal with it? It was Nietzsche who said, whatever doesn't kill us makes us stronger. Well, tell that to these guys, it has quite a bit of significant consequences as well. There are brain changes. Quality of life goes down. Function goes down. There's sympathetic hyperarousal. Cardiac events can occur, sexual dysfunction. Suicidality is a very big deal, particularly in PTSD, discognition, financial burden. This, of course, is not the complete list, but we need to pair this together in relation to what do we do on the treatment side of things, which is the better way to go for these individuals. So how do we do this work? Well, the basic principles have always been there with us. If we're choosing a therapeutic intervention, whether it's a medication or a non-medication approach, does it work? Does it work without side effects? If there are side effects, are these side effects manageable? And then there's sort of this new thing on the block, relatively new over the last number of years. Does it work over a long period of time? And do side effects develop over a long period of time? And, I grew up in the day, it was a long time ago, where, if you didn't see the side effects in the first few months, it's probably not going to happen. Well, that's not necessarily true. And what we now know is that we have translated the information about medication use for peripheral non-central nervous system reasons into central nervous system applications. And so, for example, if the study for a beta blocker for hypertension works for 3 months, 6 months, 1 year, we could probably use that long term. Well, with neuroactive agents, we now recognize that these agents really change the neurochemistry in a significant way, and you can't necessarily rely on those shorter studies to really tell you the answer in relation to what happens over the long term. Another way to look at this is from the perspective of what we do or should be doing with informed consent. And that's the medical decision-making that involves outlining the risks, the benefits, and the alternatives. So let's take a look. The benzodiazepine risks, they are significant. We can get sedation, dizziness, vertigo, fatigue. A lot of those after initiation will improve, at least for the short term. Dyscognition can occur. There's, of course, confusion, anterograde amnesia, memory problems, attention problems, psychomotor impairment. There is a long list that involves falls, fractures, incoordination, ataxia, and so forth. And then there's this category of disinhibition, which may or may not include paradoxical effects. This is where excitement can occur as opposed to relaxation in these individuals, irritability, aggression, hostility, and impulsivity. And we see violence associated with the use of benzodiazepines, certainly in a number of individuals as well. Other adverse mood effects, emotional blunting, whatever takes the bad stuff away tends to take the good stuff away from individuals. And anhedonia can be really quite prominent. We see mania, depression. Certainly, I remember the days when alprazolam was suggested as an antidepressant. And those of you that are old like me may recognize that kind of push way back in the day. Well, it's true, you kind of get this flavor of improvement over the first couple, 3 weeks, but the studies universally have shown that at 8 weeks, the depression antidepressant effect goes away, and indeed it gets worse over time. There's tolerance, there's physiologic dependence, intoxication, addiction. We'll talk a little bit more about that, as well as withdrawal problems for these individuals. And then, of course, respiratory depression, overdose, and overdose death. So particularly in the combination with opioids, it's a challenge to kill yourself on benzodiazepines alone. Takes a lot effort, but in association with opioids can significantly result in a higher frequency of overdose death or near death as well. And this is really important. Those of us practicing in pain management as well recognize that the connection between the two is a very big deal, but it's a real challenge because a lot of times in pain management at the end of the visit, I have my concerns, the patient has their concerns about the pain, and it often ends up as a debate, my opinion versus your opinion. So what I learned from diabetes care is that when you get a hemoglobin A1C of 11, it's diabetes. The debate is over. Now what are we going to do about that? Do we have a test then, is what I was thinking, in relation to this particular category of medicine that can answer that question. And finally figured it out. If I hadn't been a forceps delivery, I could think of these things much quicker. But finally I did, and that is we can do overnight oxygenation studies, the nocturnal oximetry, the sleep studies that can identify individuals that are at threshold for respiratory depression. And so we can do that in pain management practices and for the individuals that might be on monotherapy benzodiazepines as well. And we know that overall mortality does indeed go up associated with benzodiazepine use. What about this issue of over time? Over time, we see depression getting worse, dyscognition, and now there's developing data that there may be an association and perhaps even causal in relation to dementia. Of course, addiction, we don't know the real rate of addiction because the application of the criteria, I think, are problematic in all the literature. But it's probably pretty rare for these individuals. We do know, for example, that in cannabis, the addiction rate, about 2% per year, will develop the disease of addiction until you hit that 10% level, or therefore, or about that much. But we haven't explored that, and it's an example of how we really haven't looked carefully after we assumed that we knew what was going on with benzodiazepines over time. And then there's this issue, and Carrie highlighted it with a lot of her symptoms, and that is sensitization, the central nervous system sensitization, kindling, and wind-up. So it's the wind-up, the hypersensitivity reactions that can occur that appear to be occurring in individuals, subset of individuals that are exposed to benzodiazepines. Kindling, if it's a term that you're not familiar with, came up in the alcohol literature where repeated alcohol withdrawal results in much more difficult withdrawal subsequently. It sensitizes the nervous system, and that literature is now developing in relation to benzodiazepines. And so we see that, as in Carrie's story, that individuals that are on benzodiazepines may have greater anxiety while they're on benzodiazepines than they did preceding its use. There's a landmark study by Heather Ashton that frankly has not been repeated. 1987, where she took 50 individuals that wanted to come off of benzodiazepines. Almost universally they had anxiety. Almost universally that anxiety was described as being worse than before when the anxiety was treated before the benzodiazepines were initiated. And get this, 20% of these individuals had agoraphobia that started while on benzodiazepines. And all of this trended to improvement when individuals came off. Gives one pause to think about this in relation to what we are now becoming more understanding with regards to opioids. Opioid-induced hyperalgesia, there may be a true parallel here that there could be benzodiazepine-induced angiogenesis as well. Neurologic symptoms. Carrie also described the pain syndromes that she has, hard to put together with what our current understanding with the receptor is, but we see pain syndromes reported not infrequently among individuals that are struggling, the persistent withdrawal piece as well. And get this, clonazepam perhaps associated with cancer. A lot needs to be found out. So why are we using these agents at all? You probably recognize this guy. Hippocrates, remember, primum non nocere, first do no harm. How many of us believe that? I don't. I do harm all the time. I do economic harm to every patient that I've seen. I give them medications that have side effects, and I continue those medications if those side effects are limited. So we do less harm. And so we have to recognize and really position the way that we're looking at this and think of it in terms of what about the benzodiazepines? Well, functionally impaired individuals with regards to anxiety, maybe for a short-term use, 2 to 4 weeks, but beyond that, there is a greater chance over time of inducing harm. We want to minimize all that. So where are the benefits? We do see first-line indications for benzodiazepines. Status epilepticus as a procedure amnestic. Frankly, I don't really want to know about my colonoscopy during the procedure. Alcohol withdrawal, it is a standard and very important. Incidentally, I think it's useful to know that lorazepam and oxazepam are probably the better agents because they don't require a liver to process, and a lot of these individuals have liver impairment from their alcohol addiction. And we use it for a variety of other things. It's not a complete list. We have movement disorders, muscle relaxation, of course, anxiety states, insomnia, seizures. You can add tinnitus to this as well. But looking at anxiety in particular, short-term efficacy has indeed been well demonstrated, and there's much literature in relation to that. However, we also find that this benefit tends to decline in a significant portion, we don't know the exact number, after initial benefit. And this is where the research is really absent. Long-term efficacy, however, has not been demonstrated in research, and there are individuals that claim its utility, but indeed the research does not yet support that as well. And indeed, as I mentioned earlier, benzodiazepine withdrawal can actually improve anxiety rather than making that worse, something certainly to look at. So what about the alternatives? Well, there are a lot out there. They're in the pharmacologic range. There are adrenergic agents we use a lot in primary care, monoamine, serotonin active, dopaminergic, sodium channel blockers, glutamine agents, and of course plant-based medicines. And I know what you're thinking, cannabis, right? Right off the bat. But cannabis, the cannabinoids actually do have an effect on the GABA receptor. Anything that affects the GABA receptor, I worry about. I'm not real excited to think that maybe 20 years from now, we're going to be telling our current individuals, oops, sorry about that recommendation, because that didn't work out just like the benzos didn't work out as well. But what's really interesting to me is there are a variety of other plant products, passion flower, for example. Lavender was really interesting. There's a small study out there comparing it to lorazepam, equally efficacious. So the cool thing about lavender is that it works through the serotonergic system and not through the through GABA as well. And then, of course, what really needs to be emphasized, there are a lot of things that individuals can do to deal with anxiety, and this all has data. It's in the supplements to the sides. Self-directed after training includes exercise, movement meditation, mindfulness, relaxation, spiritual practices, all have data associated with that. And then professionally directed treatments as well, cognitive behavioral therapy, acceptance and commitment therapy, acupuncture, massage. The data is somewhat limited. We don't know about durability over time, but the data is indeed there and something for us to consider as well. One of the first things that we need to do, again, back to Osler, is to remind our patients not to take a medicine. We don't have to medicate everything that shows up. And indeed, with neuroactive agents, it probably is more problematic than we give credit for. So what about in clinical practice? For crisis-level anxiety, yeah, benzodiazepines do have a role, excepting when psychosis is involved, and the second-generation psychotics are felt to be the way to go in that circumstance. For anxiety disorders, short-term use, but I would encourage you to think of this as a bridge for other therapies to come into play. Because it's going to take me a moment to get an individual over to a therapist to engage in cognitive behavioral therapy, first to get the visit and then for the process to actually start to work, but as a bridge for those individuals that are functionally impaired from their anxiety. We don't have to treat all anxiety, but if there is functional impairment, I can't get up, get out of the house, do anything, we can bridge that temporarily while we're getting cognitive behavioral therapy underway. The other medications, the SSRIs, SNRIs, take 2 to 6, maybe even 12 weeks to become efficacious. Not that I want the benzodiazepines aboard that long, but probably the quickest acting is actually pregabalin, which may take just a week to initiate its beneficial effect. And we do know that cognitive behavioral therapy in comparison studies works as well as benzodiazepines, and that acceptance and commitment therapy, similar to CBT as well. And then in anxiety that's connected to PTSD and OCD, the data really shows very clearly that benzodiazepines never are of benefit in relation to that. And think of PTSD in particular. Individuals that might be taking a benzodiazepines could be disinhibited by the benzodiazepines and create the circumstance where more violence and inappropriate behavior occurs. But let's say we do take the leap and provide benzodiazepines. When do we limit, when do we stop that use? Well, fairly universally, the recommendations out there look at 4 weeks or less as the limiting edge of this. is the most frequent recommendation. There are a lot of guidelines that are out there. I count 17 guidelines that call themselves guidelines specific to benzodiazepines. Now, these are not real guidelines in large part. They are guidance, because guidelines now are really defined by a set of rules using typically grade methodology that assesses bias and how do you combine results, and all of that is a science in and of itself. None of these, excepting one by Patti et al., has that level of really attention to this whole thing. And that in that particular guideline, which is excellent, by the way, the focus is primarily on elderly and insomnia. So there are there are, again, to remind you, there's some reviewers that conclude you can do this long term. And I'll never say never in medicine. It is certainly possible that a benzodiazepine might be useful for a select few individuals on an ongoing basis. But we don't know that at the front end, and because we don't know that the benefit is persistent and the side effects are not related to are related to the benzodiazepines, I think it's important to engage individuals to offer tapering for all of these individuals. You will find that out as you taper the medication, whether or not that's going to be an important agent for them. So loss of efficacy. And what happens very typically is that an individual on a benzodiazepine having accelerated anxiety, like Carrie, our inclination is, well, it worked before, I just need to increase the dose. That's not necessarily true here with regards to anxiety or insomnia. And benzodiazepine-induced hyperanxiogenesis, I think, is a possibility, needs to be examined in research. So when individuals present with benzodiazepine-related adverse reactions, don't just assume that something else is going on. It may well be the benzodiazepines. And of course, we want to follow these various elements as we go along for these patients as well. So what are these withdrawal symptoms? Carrie mentioned 90, I count 138. These are just a few of them. I divide them out into the psychological symptoms, neurophysiologic symptoms, and the somatic symptoms. They're all somewhat different, but they seem to settle into these particular domains. And actually, death can occur in the withdrawal circumstance. It's very distressing. Of course, we know quite well about the possibility of intractable seizures, status epilepticus, resulting in death, but also suicidality and possibly cardiovascular issues as well. But look at these symptoms. They, Bob did a wonderful job to kind of outline how these symptoms are off the target, off of the neurophysiologic target that we assumed would be the driver for all benzodiazepine effects and withdrawal effects as well. Electric shock-like sensations, pain syndromes of all sorts, perceptual disturbances where there's a heightened sense, very typically, of touch, smell, taste, visual and auditory sensory input. Somatically, we see gastrointestinal symptoms, diarrhea, cardiovascular fatigue. None of these are really quite a fit for our understanding of the standard physiology related to the GABA-A receptor. It gets worse. When individuals are in the withdrawal pattern, we do see, for probably the majority of individuals, a slow decline in severity and ultimate resolution. This is a lot like the addiction-prone substances that we're familiar with alcohol, with opioids. We have, for example, 3 to 5 days in your typical opioid withdrawal for the acute state, and then there's this subacute or protracted phase that may go on for even months, where there's irritability, difficulty with sleep, mood problems, things like that, but eventual resolution of that. That certainly does happen with a significant proportion of individuals that are on benzodiazepines. However, there's another couple patterns in here that really throw a monkey wrench into that, and that is there can be increased severity after an initial decline. Think of yourself in an exam room hearing that particular context and thinking, well, it's rebound anxiety. That's what's really going on. But indeed, if you follow these individuals on out, and that's done anecdotally, not in studies, so we need those studies, these individuals will have typically, most of them, ultimate resolution, even though there's this rise. There's only one other addiction-prone substance that has this peculiar kind of pattern where it gets better and then worse and that sort of thing, and that's cocaine, which tends to have an accelerated phase periodically after the discontinuation that occurs. Then, so it's very confusing for those of us in the clinical setting as to what do we do? Do we reintroduce the benzodiazepine, or do we hang in there or pull in other kind of processes as well? There is indeed prolonged severity for an indeterminate period of time. And I say indeterminate because it can go on for a while. Most of these individuals indeed do get better over a period of time, but in terms of how long that takes, it's really quite variable. And Carrie's story illustrates this really quite well. And then there's this spikes in severity overlying the other patterns, up and down. It seems very peculiar. Heather Ashton described this very well in the past, calling it waves and windows. I don't know if she got the term from patients, but indeed that's what happens. It comes up in a wave, and then I have a window of relatively decreased intensity of symptoms. Many people describe that. So how do we separate this out? How do we separate this from a reemergent anxiety problem, whether that's rebound or a new anxiety problem or something like that? So these are the characteristics that I find that are uniquely helpful in terms of determining if the symptom cluster that an individual presents with is related to benzodiazepines or not. So there may be psychological symptoms that are not present before benzodiazepine initiation, like what Carrie was saying in terms of the suicidality, or anxiety symptoms that are paired with the neurophysiologic and somatic symptoms. So it's not anxiety alone, but it's the other stuff that the other partners that it carries with it. Those somatic symptoms, particularly GI, the neurophysiologic symptoms in particular, the movement abnormalities, which can be those pseudo-seizures, so a term that's relatively pejorative, basically saying it's all in your head kind of a thing to our patients, but appears to be related in the withdrawal process. The perceptual disturbances, the centralized pain syndromes that individuals have. And it may well be connected to what we call interdose symptoms or interdose withdrawal. Individuals that are on benzodiazepines, perhaps the shorter acting ones, near the end of their dose, just before they're going to take the next dose, start having withdrawal symptoms, even though that may not have occurred at the initiation of therapy because of declining blood levels and so forth, that gets accentuated with the withdrawal process as you're discontinuing the agent. Then the symptom decline followed by worsening, and then the waxing and waning symptom cluster. These are all characteristic of benzodiazepines as opposed to other kinds of diagnoses we might consider. So how do we do this? So we want to initiate the conversation. It's important to plan before doing anything at all. And it's important to have a lot of support in relation to that. Friends, family, peers, that kind of thing. Brief intervention has been found to be useful. Just giving advice. There's a strong literature in sending out a letter saying, why don't you look at this, and patients showing up and saying, I want to get off. Self-help book studies. The goal, of course, is complete benzodiazepine discontinuation, but it's really important to manage the underlying condition while you're going along. Don't neglect the anxiety disorder that the individual may have. And informed consent, which involves, of course, education. The Ashton Manual, really central to all the work that we do, and, of course, peer coaching, that includes online as well. And then the consideration of switching to a long-acting GABAergic agent. So the category of medicines, the benzodiazepine receptor agonists, including short-acting and long-acting agents. There are long-acting ones out there as well. Somewhat outside of this classic category is phenobarbital as well, but the one that we use mostly in this consideration is diazepam, with about a 20 to 100-hour half-life. Don't confuse half-life with symptomatic relief. Individuals that use this may be dividing this several times a day in order to be able to manage their withdrawal process. So the half-life doesn't necessarily describe the best way to dose a particular medication, but nonetheless, the long-acting seem to be beneficial. Clonazepam is another. It is less useful, perhaps, in a general way because diazepam exists in doses that are easier to reduce. And so, for example, 1 milligram of clonazepam is approximately 20 milligrams of diazepam. So it's easier to reduce 1 milligram of diazepam. Reducing 1 milligram of clonazepam is a reduction of 20 milligrams equivalent of diazepam. And then phenobarbital, which, by the way, probably has maybe its best utility in individuals that do have the true disease of benzodiazepine addiction. Doesn't have that salience, as we call it in addiction medicine, that attractiveness, that kind of high or connectedness that individuals have in relation to the benzodiazepines, which is very helpful. And then to taper very slowly, avoiding as-needed dosing, because remember the kindling effect. Repeated on-off of a particular medicine can sensitize as well. And you want to adjust the dose with the patient, who should primarily be guiding us in that regard. We're not used to that. We're used to kind of running the whole show, right? Frankly, there are a lot of us out there with not just an MD degree, but the MD degree, where we think we know it all, and indeed, we don't necessarily. You can follow symptom severity. There are 6 scales out there that describe symptom severity. The one that's most often referred to is the Clinical Institute Withdrawal Assessment Scale, CWA-B, to kind of pair along with CWA-A, which is alcohol. I don't find those being particularly useful because it's not a total number that's associated, but it's actually the specific symptoms that the individual has in withdrawal that really need the kind of attention in terms of how things are progressing and what to do next. We can add therapies to the tapering process. Psychological therapies like cognitive behavioral therapy has benefit. Adjunctive medications, carbamazepine has probably the best data. There's limited data for a variety of other agents. Gabapentin, not up here, but actually anecdotally has been found to be useful. It has its own problems. Remember, we now are recognizing respiratory depression associated with gabapentin use, and we're also recognizing that there's a small fraction of individuals that are using it as if they were addicted, and they probably are addicted to that substance as well. And it takes a lot of skills on our part, particularly patience, particularly collaboration. Don't work without a net. Don't do this on your own. Motivational interviewing, the skills that we learn in relation to that. And I think that the real key to all of this is the skill where, what are your goals in life? What's the current behavior? And is your current behavior going to lead to those goals in life? And you allow the patient to describe, I guess that's not working, can you help me, rather than me lecturing to the patient about what to do next. I remember the old days when we had the your lungs look terrible, don't stop smoking. We kind of threaten them in relation to that. No, it's much better if the patient takes ownership of the nature of the problem, even if it's an occult nature of the problem. We don't know yet that the benzodiazepines are necessarily causing your dyscognition, but there's a very good chance that they are, or at least in part contributing to that. Let's look at that, and now what do we do about that? And most important, listening. And what I've found is that, and I think everybody's experience here today, is that Carrie and others have extensive knowledge about this. They have spent a lot of time, true, Dr. Google, but there's a lot of good information out there as well. And within those communities, and I've taken a look at that and worked with them in that regard, that particular group of individuals does a very nice job. So why are they out there and not working with us? Why didn't they work with me and were lost to follow-up. We don't know, they didn't like the bill or, the attitude of the receptionist or anything like that. We don't know the answer to that, but and I'd like to hear more from Carrie about her thoughts on this, but I think that a lot of this is a group of individuals that is invisible to us, hidden in plain sight because they have left our practices. And the original researchers did not see that because the observation period was not long enough to identify the challenges that these individuals have. So there's a conversion table to do this transition from short-acting to a long-acting. The one that is relied upon in particular is Heather Ashton's clinicalculator.com actually includes some references there as to where they drew their sources as well, and includes a range, and the range is in there to indicate that indeed not everybody is going to land specifically on the calculation that Heather Ashton has or the average dose, but the range is really important to recognize. Remember, these studies, just like the opioid studies, were done on pristine patients that don't have other medical problems going on and are taking a single medication, and it's looking at anxiety. It's not looking at withdrawal in relation to that, but Heather Ashton actually had a very good handle on this, although we do recognize today that there is a subset of individuals that don't quite match up with her particular table, and so in terms of the transition, it's important to settle in with this transition and then make sure that they maintain on the long-acting such as clonazepam diazepam or others before launching forward in terms of a tapering process. As you can see, 1 milligram approximates diazepam 20 milligrams. Same thing with alprazolam. These are approximations. This is not strong evidence base. It's based on experience. So it's important to recognize, too, that the withdrawal effects can occur with individuals that are on usual doses or even very low doses, or even for a short period of time. So again, I think it's important for us to recognize that 2 to 4 week window, this is the time to introduce the recommendation. Let's see about tapering that. Add in other things to address your insomnia or anxiety disorder while we're doing that. And best done with patient guidance. This is a shared decision-making process. It should be thought of in terms of it's going to take 12 to 18 months at the front end. It may be quicker. It may be much longer. Carrie, spent 38 months in this particular process, and so I think a good starting point. And again, this is not evidence-based, but this is a basis of experience and what individuals have gone through, and then to address their responses by saying, "Hey, that 1 milligram reduction of diazepam was a piece of cake. I'm going to go to 2 next time." And so you can accelerate the speed of the withdrawal depending on their response, and you could slow it down equally so. So it's not only the dose reduction, it's the interval between the dose reductions. And this is particularly important as well. Withdrawal is very, very difficult to hang in with if it's continuous on a regular basis without any relief. It's really important to have a pause in the intensity before the next reduction takes place. If that next reduction takes place in 4 months, so be it. It's going to have to be in that particular way depending on the response of the individual. And we're all in on this. Don't work without a net. The pharmacist in particular, I think, is going to be a valuable partner in this process. Of course, the prescriber, the psychiatrist to look for alternatives, behavioral health, peer coaching, and of course, the patient. Did I mention the Ashton Manual? It's really important. So what individuals have found in their online communities is micro-tapering. Technically, this is very challenging. We have compounding pharmacists that are trying to do that. It's challenging for them, and it's performed by patients on their own. This is obviously way off label, but they've gone to that level of desperation rather than coming to us. Very small decrements, most easily done with diazepams. You can do it in two different ways. There's daily microtapering, where every day you take off a little bit more, and then there's the cut and hold method, where you take off maybe a bit larger amount, but then you stay with that amount for a week, a month, or even longer before making the next reduction. And it's done with a razor blade and a jewel scale. It's done by mixing it typically in water. They don't mix very well. It's primarily a suspension. Individuals have to become adept at making sure that the shaken up product is sufficiently mixed before taking off about a cc after they mix it in 100 cc's, and then taking the remaining 99 cc's. And you can see how errors come into play significantly, and that can be very important for patients. It is not FDA approved and not studied, but our patients are resorting to this because we haven't been there for them. So don't delay offering the tapering process. When individuals are on opioids, which is a major contributor to all of this, you can alternate it. The problem in pain management is that we're focused on opioids, which of course we should, but we neglect the benzodiazepines. And I'll get to that someday often means I never get to it. And so we can alternate the tapering, because the tapering of opioids may require reductions every other month as well. Motivational interviewing. We make judgments but not be judgmental. We want to manage their expectations, continuing to gauge support and collaboration. The Ashton Manual, it keeps coming up, right? Peer coaching, shared decision making. And then we want to follow, for those individuals that choose not to taper, we want to follow along with them, how is their cognitive status in particular, and how is their oxygenation doing in particular. And if we get into a very critical situation, we use that objective data to say, we got to move this because you're in danger. And providing assertive guidance, no is a complete sentence, sometimes need to occur. If that nocturnal oxygenation study indicates that patient is more than 10% of the time under 90% saturation, Houston, we have a problem, and we need to address that, the opioids or the benzos as both, and do that quickly. So circling back, Bob's wonderful presentation laying out the challenges that we have in terms of understanding this. These are GABA receptor functions. Where do the other withdrawal symptoms come from? The neurophysiologic, the somatic symptoms not well explained by GABA. The translocator protein, which is the peripheral benzodiazepine receptor, may be an answer to that. Look at all the functions that are subserved by this particular protein as well. And we do now know that the translocator protein is involved in benzodiazepine withdrawal. This is not just of academic interest. It's certainly academically very interesting to all of us because it may explain adverse reactions, it might explain withdrawal reactions, it might provide future therapies, but really critical right now, it validates the benzodiazepine survivor experiences. These individuals very typically come into offices and are told it's essentially all in your head. You're crazy. It's psychosomatic. And indeed, these symptoms that look very bizarre, very odd, go up and down all the time, indeed can be a reflection of benzodiazepines. So it's important to engage these patients where they are. And first of all, learn the language. This is a group of patients that call themselves survivors, and they are. It's a heroic venture, truly. We want to become benzo-wise, adept at this, and that's benzo-informed, but also listening to patients and responding to their particular concerns. Benzo brain injury is what typically is being described by the survivors, and this reflects persistent and adverse withdrawal effects. We have no name for this in medicine at this time. I would propose benzodiazepine injury syndrome, and the reason is the indefinite nature. The implication when we use the word protracted withdrawal is that eventually it's going to go away. And that probably is true for the majority, but some individuals have residual symptoms, maybe minor, where we do think that neuroreadaptation is not going to take place fully for some of these individuals. The waves, periods of increased intensity, windows, periods of decreased intensity, micro-tapering, dose reductions that are not reflected in pharmaceutical formula products. So listen to your patients. The Ashton Manual. Limit the initiation of benzodiazepines, but not in PTSD or OCD. Limit initiation of duration of benzodiazepine use 2 to 4 weeks. For those struggling with long-term use, don't assume that these symptoms require an increase in benzodiazepines. Don't assume that this is addiction. The challenges very rarely are associated with addiction. Recommend tapering to all that are on it to discontinue them ultimately. If they decline to do so, monitor and manage that particular risk. If it's accepted, plan first, share the decision-making, consider substituting with a long-acting benzodiazepine before tapering. Think of tapering in terms of 12 to 18 months to begin with. You can go faster, you can go slower as you go along, and then adjust the dose and the interval between dose reductions as patient responds to that. Add cognitive behavioral therapy, consider adjunctive medications, avoid the updosing and as needed benzodiazepines, which can cause kindling and make subsequent reductions more difficult. As you are completing the withdrawal process, slow it down. It's just like working with a corticosteroid. You slow it down as you're approaching the end of the tapering process. If symptoms persist, continue to support and encourage. Listen to your patient. They often have the next best idea. They really do. And the solutions really are iterative. It's between, how did it work? How did it not work? Everybody, indeed, is truly different. There are 6 gravestones around the world with the words, "I told him I was sick." And it really drives home the point that we need to be listening to our patients. We struggle these days with this evidence-based versus personalized divide. And what happens here is that evidence-based medicine, very valuable, very helpful, very important, very limited as well, because the studies are set up with exclusions, and very typically it describes a generic patient. Well, the person sitting in front of you is not a generic patient. It's very much personalized. Some individuals will have virtually no trouble whatsoever making a withdrawal occur in a rapid fashion. Other individuals will be enormously challenged by it. And indeed, evidence-based personalized medicine is really what it's all about. We need to personalize it to the characteristics and the response that the patients truly have. So I want to end by acknowledging all the benzodiazepine survivors who kept courage when we weren't listening, and I include myself in on this. We weren't, and that's why they went elsewhere, and they sought out the help where they could get it, and the better help online communities. We need to re-engage this particular group of individuals and assist them in that process as well. So Rumi, probably the best poet ever, not evidence-based. Rumi, probably an alcoholic, said the words, "The wine we really drink is our own blood. Our bodies ferment in these barrels. We'd give up everything for a drink of this. We'd give up our minds for a sip. Soul drunk, mind ruined, these two sit helpless in a wrecked wagon. Neither knows how to fix it. And my heart is more like a donkey mired in mud, struggling and sinking deeper." It's certainly addiction. That experience, though, is what individuals with benzodiazepine injury syndrome are actually experiencing as well. So we need to be there to assist them in that particular process. Thank you.
Thank you, Dr. Wright. Dr. Wright presented a lot of really good information, and he graciously said that he will make all that information available to you. So if we have a mechanism here, or if you just want to contact Dr. Wright directly, we can do that. We're actually right on time here, so this would be our break time. We had scheduled a half-hour break. We could shorten that to 15 minutes. It's totally up to you. What is your preference? I want to be sensitive to your time schedule then. 15 minutes, is that good? And then we'll come back here at 3 o'clock. Todd, is that okay with you to start at 3 o'clock? Okay. All right, very good. Thank you.
I got some laptop audio, Jeff. Thank you.
Okay, everybody, well. I'd like to introduce our next speaker, Dr. Todd Vanderah. And it gives me extra pleasure to introduce Todd. I've known Todd for quite a while. And you're going to have to wait. You're going to have to listen to this very nice, embarrassing introduction. Dr. Vanderah is, a real superstar in the area of CNS research, and he has been involved in many aspects. Every time I think I come up with an idea, I look in the literature, and then he's already published a book chapter or papers on it already. And he is a premier teacher here, and he is now head of the Department of Pharmacology here, which, for those of you who don't know, but for me, that is an amazing title. The Department of Pharmacology of the University of Arizona is and has been through decades one of the premier pharmacology teaching and research departments in the country. I named one esteemed investigator already today, Dr. Yamamura, but it's just a long list of very prestigious people, of which now Todd is listed amongst them. So Todd very typically got interested when he learned about the benzodiazepine situation and the patients, and he is now going to talk a little bit. He just started on some basic research into the area, and we think he's probably the only one in the country who is looking at this with such expertise and enthusiasm. So, Todd.
All right. Well, thank you, Bob. That was very nice. So, as Dr. Roffa mentioned, I got into this because there's very few people looking at benzodiazepine and addiction and withdrawal. And I've spent almost 20 years working on opiates. I was one who, many, many years ago, told the pharmaceutical companies that these opiates were addictive. Imagine that. But of course, they didn't want to listen to a lot of that. But we actually did a lot of work on opiate addiction. I do now currently a lot of work also on cannabinoids and trying to understand how cannabinoids work. But one of the things when Bob came to me and said, nobody's doing this work on benzos. And so I thought, well, why not? We do a lot of work on different types of addiction and withdrawal. And so we started with alprazolam, of course, Xanax, and we wanted to look at whether it would produce rewarding effects as well as withdrawal. So what is alprazolam? I don't have to go into detail now after all of the prior lectures, so I'll go more to how we think it's working. And so, of course, we know that it works at the GABA receptor, but I'm going to talk a little bit more about this translocator protein as well. But we know that it works at GABA receptors. So normally, of course, you're going to have GABA as an inhibitory neurotransmitter. That works at a GABA-A, and it allows some chloride to go in. And so it kind of affects the kinetics of the channel. And, of course, these are found all over the brain, as Bob had pointed out, and they tend to sort of slow down neuronal function. Of course, when you add on benzos, what they do is they'll actually bind to their site on those channels, and they actually work with GABA. And what they do is they allow it to open, but they allow the channel to continually open. And so it kind of increases the frequency of that channel opening, so you continue to get more and more chloride flowing in, so it's slowing down the CNS. As mentioned, alprazolam is a drug that, of course, has been prescribed as seen here, and there's no pointer, but obviously number 19 right there. in which there's lots of prescription. And I just looked, this says 2016, but even in 2019 now, it's probably going to be right around this number 19 as one of the top prescribed drugs. So benzos, what's the problem? So obviously they're frequently prescribed for long-term use, which we don't believe is proper, and I think you've heard a lot of that today. Of course, we know that it's safe if it's used effectively and for a short period of time, but it's all about what we're talking now is this chronic use of things like Xanax or alprazolam. So again, major indications is for short-term use in anxiety. So long-term, we know that there can be dependence and withdrawal. And of course, a lot of this is just clinical. But if you look in the literature, basic science, there's just not a lot of studies that have actually showed whether benzos can produce addictive properties in animals. And so that's some of the stuff I'm going to show you. And then we started looking at withdrawal. So what's the problem with long-term use? Of course, I think we've covered this. So for the sake of time, we'll move on. We've also seen that there are many deaths due to benzos, and so again, the correlation between benzos and opiates have continued to increase, with somewhere around 11,000 in the combination in 2017 there. And so we can see that benzos, there's lots of dependence in which you can see dependence continually increase, so if there's longer use and higher doses, you'll see that there's going to be greater dependence in using something like Xanax. And of course, if you look at the patients who take benzos for more than 1 month, 47%, that's almost 50%, will become dependent on these particular drugs. Benzodiazepines, of course, produce a withdrawal, and so we're going to talk, and you've already heard a lot about it, so I won't go through all the details here for the sake of time, but we do know that benzos can produce a number of different symptoms. And again, most of this is usually going to be reported in humans, but again, I do believe that this is going to cause this in animals, and this is something that we're beginning to study. So what is the mechanism then of benzodiazepine? Both, I want to look at addiction or rewarding behaviors as well as withdrawal. And so we set up some aims, and again, the first aim is to establish whether an animal or a rat model can be produced in which you can actually get reward in these animals. And again, this has been questioned if you looked at it in the literature, is are they addictive and can you show this? Aim 2 will be to look at whether withdrawal behavior in rats occur following chronic alprazolam. And then we're also going to determine the molecular mechanisms of rewards. And so is it through the the GABA A receptor or is it through this new translocator receptor? And so, again, we want to do all this in order to begin to work on how we can come up with novel therapies to prevent reward and withdrawal. And so let's look first at the first aim. If we look at establishing rewarding activities, you go to an area in the brain called the ventral tegmental area within the brainstem where your dopamine is stored. And so this dopamine, we know that pretty much every substance of abuse will cause an increase in dopamine. And that dopamine gets released, it goes to a certain area called the nucleus accumbens that gives you the rewarding or euphoric feeling. And so there's no doubt that there's the same type of thing that's going to happen in the particular GABA. You'll see there on the left that the dopamine cells, which are actually in the red on there, they're always under GABA influence. So they're continually on this break. And so the GABA will continue to go out, work at that chloride channel, and just sort of slow the dopamine activity. Any substance that then causes the inhibition of that GABA or stimulates those dopamine cells are going to increase the amount of dopamine. So again, when you look at the left, you can see that there's a certain amount of dopamine, and of course that GABA, that green neuron, will have things like opiate receptors, and when we know that when you give opiates, like a mu-opiate agonist, like morphine or hydrocodone, they actually shut that GABA neuron off, the dopamine goes, and of course it releases that dopamine into the nucleus accumbens, and you get rewarding activities. For GABA, it's interesting that you have the different types of GABA receptors. So if you look on the right now, and we're thinking about with benzos, because this has always been a big question, is how does a benzodiazepine actually produce more dopamine release or more reward? Well, if you look in the literature, what you'll see is there's different types of GABA channels. So just as Bob Roffa had showed that you have different sort of subunits of this GABA chloride channel, we know there's different subunits. And you can see that the red channel, the alpha 1 versus an alpha 2, that there are different types of GABA subunits. And so you'll see that there may be more of an alpha 2 sitting on the dopamine neurons on the red, the blue color, versus the alpha-1 subunit on the GABA neurons. And so when you use benzodiazepines, they may very much affect one of those channels, in which you'll notice that on the right that there's less of the actual GABA coming out. Why? Because the benzos are going to affect more of that subunit, the alpha-1. And so you have much less GABA that sort of takes off the brake, and now you release the dopamine. And so the dopamine gets released, and so you can see on the right you have way more dopamine. And so this is the going theory coming directly out of NIDA to suggest that this is how something like a benzodiazepine can be addictive. And so with that, we went to study, and we have a nice little model in which we're going to use conditioned place preference to determine whether the benzodiazepines are addictive. This is a typical model. It's a simple behavioral model in which you can train animals, and just as in the title, it's a conditioned place preference. So if you keep giving them the same type of drug in one area, will they keep going back to that area? And so in this particular one, first you take an animal and you put him into a box. This box has 3 chambers, as you can see. The middle has a light. The side on the left has some striped bars and a flat bottom. The one on the right will have a little bit of a rough bottom, but it'll be not striped, it'll be solid colors. And all the light intensity will be about the same. Now when you put this animal in there, what the animal will do is it will explore both sides, and it will spend about 50% on one side and 50% on the other. And you can record his time. You can do this twice, take an average. But in general, animals like to explore, and so they'll spend 50% on each of the sides of the box. And you record that. So, of course, then we can actually give them drug. And we can give them drug, and we can put them in one side or the other, and we can actually close the door. And we can do this for 1 or 2 weeks straight, in which the animal will receive a certain amount of drug on one side for 2 weeks. And, of course, we can do that with vehicle, but if the animal is something that might be addictive, you know that he's going to actually end up coming back to that particular area. Again, you can do this with vehicle, in which you can move the animals into the other side. So you can compare between the benzo and your vehicle. And then, of course, this is what our schedule looks like. So we're going to be able to do a baseline. We'll record how much they spend on both sides. We then will start with either a benzo or a vehicle treatment. We again go over the 2 weeks, and then you'll see on test day there that we will now give or put the animal back in the box, open up all the doors, you give them no drugs, and then you look to see, does the animal go to the side where it continually received benzodiazepine or not? And so you can do this. Of course, this is what we call test day, in which, again, the animal's not on drugs, and you basically look to see how much time they spent on that particular side of the box. All right, and so, again, this is what our actual data look like now with alprazolam. And so you can actually begin to determine how much the animal spends on each side. So first you can look on the very right there in the gray, that's the neutral. And so in some cases the animal will spend pretty much neutral time on both sides. So probably just like humans, not all animals are going to find benzos addictive. But if you look at the blue, you'll begin to see that there are many more animals that were receiving the alprazolam that actually were going to the side of preference in which they received the alprazolam, suggesting that it is a drug that can produce rewarding behaviors, and that the animals prefer that. Not all animals, but most animals. There's a few vehicles that are also on that side, but in general, the animals would prefer that side. And so this is actually when you add up all the data, and you look to see, is there a different score? And you can see that alprazolam will actually produce what we say is a positive conditioned place preference. And so this study is an animal study in which it does demonstrate the fact that something like Xanax can produce rewarding behaviors in animals. And so again, you can plot this data any way you'd like. You can see that, again, alprazolam, as compared to their baseline, the animals are preferring the actual alprazolam, and they're going to the side where they actually receive that drug. And again, just another way to sort of show that data. But again, we think that it is producing rewarding effects. So the next was to actually do this. We actually are going to be doing this in male and female, I should say. The next was sort of to look at the mechanisms. And so even though this is aim 3, while we're doing conditioned place preference, we wanted to know, was it through the GABA-A channel, or is it through this new translocator protein? So we repeated this using some antagonists. Again, we can use a GABA-A antagonist that blocks that site. And we can also use an antagonist for the translocator protein. Now, this has been mentioned a few times. Bob first referred to it as this peripheral benzodiazepine receptor. And so we have great interest to know what its role may be playing, both in addiction, but even more so in some of the withdrawal studies. And so this is the first study that actually looks at not only can we prove that there's conditioned-place preference with Xanax, but that it may actually be blocked using something like the flumazenil, which is the GABA-A antagonist, in which we can reduce the amount of rewarding behavior in these animals. So, and again, you can see the cumulative there on the right. And so it looks as though the GABA-A antagonist may actually block the Xanax rewarding activities. We, in AIM 3, okay, so now we're looking at AIM 2, in which we're looking at withdrawal behaviors in the rats. And so we started with a paradigm that was very similar to the last one, in which we were giving 3 milligrams per kilogram. In this particular studies, we noticed that if you don't give the alprazolam every day, we don't see severe withdrawal behaviors. And so we realized that now we need to actually give the alprazolam every single day in order to be able to see behavioral withdrawal. And so, again, it's a pilot study in which we started to look at this. So we're going to give 7 days daily injections of alprazolam. And we're going to be looking at a number of different types of behavioral tests in order to determine whether we can actually see withdrawal. And so, again, the first study was 7 days. We're going to actually also be doing a 14-day study in which we can give it twice a day, sub-Q, and look for all the different types of withdrawal behaviors. But this is a study that is just up and going right now. Finally, I just want to mention the other receptor for mechanisms. Again, this is this translocator protein, and this is one I do have to give credit to Bob, who actually brought this. So it wasn't my idea, but did say we should look at this because it seems like it's a peripheral benzodiazepine receptor that may actually play a big role in the withdrawal part. So not so much the addiction, but more withdrawal. And so I find it very interesting. It's a receptor that is big as far as steroid metabolism, and I find this very interesting. So it's located on the mitochondria, as Bob showed, all over the body. It's thought to play a role, obviously, in metabolism, but it also may play a huge role in the synthesis of steroids. So using cholesterol, we know that all the steroids will come from cholesterol base. We often think of that as happening in the liver, but it's also occurring here in the mitochondria. And so, we want to look at the TSPO, both for the steroid thing, but the porphyrin rings, the DBIs, so there's all kinds of things, and even endozapines, which there's actually endogenous benzodiazepines within there that may be acting at these receptors and that may be affecting all the current events. So, but again, we don't have any data yet, so we should have more data within the next month or so to determine whether we're getting withdrawal effects and then whether it's blocked by the TSPO antagonist. But again, to mention there, you can see that the receptor may play a role in things like hormones and the HPA axis. I truly believe that is happening, so we'll measure there. The autonomics, as well as even kidney function and blood pressure. And so the idea here is to say, does this have an effect? And you'll see some of these papers, they were published a while back. And so, again, it was mentioned the fact there's been very little data and really research in this particular area. And so, it's kind of nice to dig back into the literature and to find that it hasn't been studied, but I think there's great need for studying in this area. These are some papers, again, 1999, where they first started looking for this particular receptor, showing that it is in a number of different tissues, whether it's the adrenal glands, the kidneys, the heart. You'll see little amounts in the brain, but more studies in the future have actually showed that it does show up in areas of the brain. So you can see here stress, acute stress in animals will produce a 35% increase in this particular receptor. They looked in the kidneys, so that's where, of course, they saw it. But you also see some in the cortex. And so it's not just all over the body, but it may actually also be in the brain. And the study on the right, it is also showing you kidney, heart, but also that OB is olfactory bulb, which I always find is interesting, is that for some reason there was a very increase after stress also in the olfactory bulb. And so, again, it's an area that we'll look at. There are some papers implementing that TSPO may play a role in chronic stress, alcohol, pain, PTSD. So, again, I think there's just very few studies to determine its role in benzodiazepine. However, it is the one thing that benzos do bind to, and then as well as the GABA-A channel. And so finally, again, we're still working on determining whether we can record a number of different withdrawals. We're looking at about 20 different behavioral measures for benzodiazepine withdrawal, so it takes some time. We have a crew that's working on it. The main crew is our team Benzo up here. Austin Thompson, who's an MD PhD here, Cheyenne Moffitt, who's also an MD student here, and Katie Coast, an undergrad. they've really taken up the challenge to say, are benzos addictive, number one, and do they produce withdrawal? And then finally, I just want to thank the funding source, as well as NEMA, and of course Bernie and Carrie for their support for this basic science research. Thank you.
Okay, well, thank you very much, Dr. Vanderah. I was extremely interested, and we can't wait to see some of the new data that's going to be coming out, and I think it's just going to stimulate more people to look as well. So we're going to open it up for questions shortly, but before we do, I just want to thank everybody who helped put this symposium on, and particularly to the speakers who gave, their time and effort and came from long distances to be here today, and I appreciate, I just want to thank the audience. I just had a chance to talk to a few of you. I look forward to talking to more of you, but it's just been heartwarming to hear your experiences and a little bit of your frustration about what we don't know about these potentially very, very good drugs, but we have to be cautious in their use. So with that, I open it up for anybody have any questions, or we welcome your comments as well. Dr. Wright.
About flumazenol and whether it's a partial agonist and or an antagonist at the channel. Is this on? Yeah, okay. And so it's a great question. It's sort of like the buprenorphine thing in the opiates, in which we know that that's also partial agonist. But again, any partial agonist in the presence of a full agonist becomes an antagonist. And so because it brings down that efficacy level of that full agonist. So there's no doubt that I think that it is a partial agonist when it first binds, but then when it gets stuck in the site, it doesn't allow benzos to continue to produce their effect. And so we look at it as, at least in the presence of the benzo, as an antagonist. Mm-hmm. Yep.
Another question, over the years there's been a real long struggle to identify an endozapine. And then an endozapine at sufficient enough levels to explain why in the world is there a benzodiazepine receptor out there in the first place. Where are we with that?
Nowhere.
Yeah.
So I don't think we know much about the endogenous benzodiazepine agonist. Again, I think once looking, the question is whether it's actually being produced in the brain and or the body. People are now describing it as more of an agonist for TSPO than maybe even the GABA-A chloride channel. But again, I think there's just been very little research in this area. I don't know if, Bob, you know any more?
I can verify that because we're actually, I'm editing a book on that exact topic, on the endogenous benzodiazepines. And I couldn't find anything recently. So what I did is I figured I'd call an author of one of the old chapters. And he just said, oh man, he says, good luck. He said he stopped working on it out of frustration because you can never quite figure out whether these were produced, in human brains, or whether they were a metabolite of something, or whether, just in our natural dietary sources of materials, maybe there's a benzodiazepine-like material, and that's showing up in our assays for the brain. However, so he stopped working on it out of frustration, and it didn't, it became an unpopular thing to do, so he didn't recommend the students study it, on and on and on. We all know that sad story. But as far as I'm concerned, I asked him this, and he hadn't thought about this. I said, from our perspective, does it really matter what the source of the endogenous benzodiazepines is? If it or they're in our brains, then what is it doing to our physiology, and what is it doing if we then take a prescription for a benzodiazepine? Are they competing with each other, or are they enhancing each other? So maybe, from their initial interest, was this synthesized in human brains or not? I don't think as clinicians we would really care. I think the fact that they're there, which they are, and the question now is, how does that influence patients who are put on benzodiazepines either during the administration or during withdrawal? But Todd's exactly right. The field absolutely came to a screeching halt because they were all arguing with each other about, well, maybe it was this contamination or that contamination, and they just couldn't resolve it, and they stopped. So I think it's a very exciting, practical question now. Were there any others? So, very good questions.
Hi, Dr. Wright. Oh, this is really loud. So my question was about the overnight oxygenation studies. How do you use that clinically, and is that some sort of modified sleep study or just a pulse oximeter?
The microphone runner.
Well, medical care is really hard to afford. And so very typically, and there's no literature on this, but I finally landed on the idea of how can I get through this debate, my opinion and the patient's opinion and so forth. I said, well, we need a number. And so I started doing oxygenation studies, just nocturnal oximetry as a screen. And if you're more than 10% of the time under 90% saturation, that screen's positive. Now you have to go and do a formal sleep study because you have to separate central versus obstructive sleep apnea versus mixed kind of conditions in order to know exactly what to do. But even with this screening data, if it screens positive, you've got leverage for your conversation about we got to do something. You get to pick, is it opioids or benzos? We're going to kind of start to tackle in that regard. And so it does a couple of things. It identifies a real risk. And I was really, really surprised. So I had a large addiction practice with a lot of buprenorphine, which theoretically has a ceiling for respiratory depression. I started checking my folks, and there was an enormous number of individuals with respiratory depression by that criteria. And of course, we'd kind of make adjustments along the way, including interventions directed towards respirations, CPAPs, and that kind of a thing. But that's how I use that.
Do we have another question up here? Great.
I have a chicken and egg type question. Is there really a benzodiazepine receptor? Now, on the GABA receptor, there's an alpha and I think a gamma protein and also beta proteins. But it seems like from the diagrams that I have seen that there's like a little place where the alpha and the gamma come together, and that's called the benzodiazepine receptor. Now, could it just be that certain chemicals somehow are drawn to that area and cause conformational changes in the GABA-A receptor, leading then to the activity that we see? The second question is, do we really know if there are endogenous benzodiazepine type substances, or was that just something that we're assuming because we now have a benzodiazepine receptor? It has to be there for some reason.
You got our juices flowing now.
Yeah. Bob, you want to answer or you want me to answer? I'll start. So there's no doubt that there's a binding pocket between the alpha and the gamma part. And we know this because it changes the actual frequency of the open. So it does. It changes conformation of the channel. Now, it works very different than a barbiturate because a barbiturate will also bind, but it'll maintain the opening of the channel. And since barbiturates are more dangerous, they can kill. Whereas benzos tend to work there as a modulator. So it doesn't actually really have a good effect at opening the channel by itself, but it almost always works with GABA. And so I do believe that it has a binding site, and we call it a receptor. I actually got my PhD with Hank Yamamura, who was studying the benzodiazepine receptor forever, and it drove him crazy because, of course, the subunits would change and depend on where you looked. The one area of research that has expanded in this area were the sleep drugs. And so all those Zs that were mentioned by Dr. Wright, those drugs actually affect a different alpha subunit. And in that alpha subunit is on the GABA channel that tends to be more in sleep areas, whether it's in the thalamus, hypothalamus. And so there's no doubt that I do believe that there is a binding pocket. We call it a receptor. You can call it whatever you want, I guess. But there's no doubt that there is something that will bind in that channel with high affinity. The endogenous, I don't know, I'm going to give that back to Bob.
Yeah, okay. So in terms of the receptor question, I think probably if this were a graduate class, we might say, yeah, we should probably use the term binding pocket. But it satisfies all the common definitions of a receptor, because you have structure-activity relationships showing affinity for this binding site, and you have a selective antagonist that will block it, going back, to the earliest extant animals. But as Todd said, is there a biological effect? Well, in the presence of GABA, absolutely. In the absence of GABA, not really. So we could quibble whether we want to call it a receptor or not. It's just easier to call it a receptor, but I think we would say if you want to call it a binding pocket, that's fair enough. In terms of the endogenous benzodiazepines, they're there. The substances are there. The question only is, what's their origin? And the consensus seems to be that the origin is not from our own brains, that either we all absorb these in our lifetimes, or they were somehow absorbed and our brains have made use of them. But the question, we don't really know. But they are there. I mean, if you take human brains and you look for substances that have structure of benzodiazepines, you will definitely find them. So that's, to me, that's my interest as well. People stop there. The question now is, well, what's the influence on us in our daily lives and when we're prescribed benzos or when we get off them? Because it's never been taken into account that if you're put on a benzodiazepine, it's on top of what's already there, whatever the origin.
So for example, valerian, which can have a sedating effect, valerianic acid actually binds to the GABA-A receptor and causes some conformational change, if that's correct. And actually there are a variety of chemicals in valerian that do that. So there is a potential exogenous source, and I don't know more diversely than that as to what's available in the plant kingdom, so it could have adapted in relation to that.
Well, I'll tell you a cute little story.
I was going to say, just correlating to cannabinoids, if you talk about cannabinoids, I mean, remember, if you go back 10 or 15 years ago, there was no endogenous cannabinoid. Yeah. Do you guys know that? Do you guys think that there's an endogenous cannabinoid? Of course, yeah. So there's now 2 different lipids, and there's probably at least 3 or 4 more that aren't discovered yet that are actually binding to the cannabinoid receptors. So I probably believe that somehow your body may be making an endogenous compound for the benzodiazepine.
Yeah. So I'll tell you a cute little story. So, this is an ancient system. So we used to do a lot of work on planarians. They're the oldest extant animal, the ones you saw in biology class, because, you cut them in half, and instead of dying, they grow into 2. So we exposed them to a benzodiazepine, and they show a characteristic change of behavior. It doesn't matter what it is. But then we gave another benzodiazepine, same thing. Third benzodiazepine, the same thing. Well, that doesn't necessarily prove anything. So then we wanted to see if we could block that with a benzodiazepine receptor antagonist or binding site antagonist, and it blocked. So we still weren't convinced. So we gave a couple of the Z drugs, which are non-benzodiazepine in chemical structure, but they bind to the same site. They produced the same behavior, and they were blocked by the binding site antagonist. So this, for whatever reason, benzodiazepines have been able to affect, or the mechanism has been around since planaria.
Maybe it's like the appendix, no longer necessary.
It could be. I think we saw another question.
Well, just along the same lines, I was wondering in the studies that were done about the endogenous benzodiazepines, is there any understanding of variation across populations? Are there certain individuals who are much higher in naturally occurring than others, or is that known at all?
Yeah, I don't know. I wasn't even going to mention the book, but I am looking for authors of chapters, and I don't know any of the answers, but that's a great idea. I think that's going to be, that should be a chapter, because that would also help in terms of looking at the possible genetic influence or the environmental influence. And then that raises, I always like looking at different temperatures, being a chemical engineer, because that could change, the biochemical routes and things like that. So I think that'd be interesting, right? So if we saw different levels in different populations, then try to correlate that with the levels of anxiety in that particular country or region. I think that'd be really neat. But I can tell you, absolutely zero is known about the functioning of the endogenous benzos to the extent that they have one. Ryan.
That's right there. Right here. Perfect.
Good, and actually my question is for Dr. Wright as well as anybody else that would like to take a crack at answering this, but it's more so in the realm of treatment alternatives. So with a benzodiazepine, if you take something like generalized anxiety disorder or insomnia, you have a patient that comes into the clinic, and it's both an easy fix for the doctor as well as the patient to say you have something like insomnia or generalized anxiety disorder. Here is a script for 4 weeks for a benzodiazepine. But I am also a big fan, at least in the idea, of cognitive behavioral therapy. Now, the downside of CBT is that it typically takes a lot longer for it to work than if you were to prescribe somebody something like a Xanax that they can take that day. So is there any in-study data that you're familiar with, whether it's Dr. Wright or anybody in the audience, that actually shows a side-by-side comparison of how long it would take for cognitive behavioral therapy to kick in and what those lasting effects are, as opposed to something like a benzodiazepine?
Not really. The studies really say, without describing a time frame, does it work as well as benzodiazepines? This is just a reflection of what's in or out of fashion, at any one time. Now that we have particular interest in pain management for non-pharmacologic approaches, I think we're going to see that shift. But no, so I think that the way to do this is that you limit your prescribing of an initial benzodiazepine to individuals that are functionally impaired by this, can't get out of the house, can't conduct their lives. It is that overwhelming in order to help them. It's sort of like with the opioids. We're looking for functional endpoints, not just symptomatic endpoints for these individuals. At the same time, you initiate the referral for cognitive behavioral therapy. Maybe at the same time, consideration for an SSRI, SNRI, or pregabalin. Pregabalin has the quickest onset of action, can be within a week, but you want to do, if you're writing a benzodiazepine for somebody functionally impaired, at the same time, do something else. In terms of durability, it's the same kind of thing with the opioids there as well. Yes, we see an uptake in terms of cognitive behavioral therapy being useful, but we don't have durability. And to be fair, you really need to have durability in there with a non-pharmacologic process, like cognitive behavioral therapy. Do you need a refresher? Can you, once you establish this, is it going to have durability? And I haven't seen that.
There is really good evidence about durability of effects on depressive disorders for CBT, which has been compared head-to-head to SSRIs. And if you follow people over the course of a couple of years and you keep people on their SSRI for 6 months until their depressive episode is finished, and compare them to people who've had CBT during that 6 months, the people who've had CBT have a much lower rate of recurrence of a depressive disorder than the people who've had CBT. So just if we're thinking about CBT as having an enduring effect, the comparison with depression treatment, I would think, suggests that there's a good chance it would be the same for anxiety.
That's wonderful. Have you seen anything on anxiety in relation, same type of thing?
I've not looked specifically for it, but I think it's worth looking for.
What about insomnia?
Definitely CBTI is better than
Better, but I mean in terms of durability.
durability.
And how much of a course of CBT? I mean, can you do 2 months, 3 months, 4 months?
I'm not a CBT expert, so I wouldn't want to say for sure, but I know that CBTI is relatively brief and effective.
It is, yeah.
And it's definitely got the U.S. Public Health Service recommendation as the #1 treatment for insomnia. There's no question about it that should be the first treatment for insomnia.
Right. We have a comment in the back.
I just figured I would pop in since, as a clinical psychologist, I do CBT every day. And I work also in a medical setting. I work in family medicine. And so to the point of the anxiety, CBT for anxiety, I agree that it's paralleled to the depression for anxiety. And usually we're thinking about 4 or 5 sessions before we see that symptom reduction. So there's a lot of research out there that supports brief CBT, which is why you see a lot of psychologists now in medicine settings, so that we can be right down the hall. You can give us warm handoffs, hopefully same day. So that way, as physicians or prescribers, if you're thinking about prescribing a benzodiazepine, you can have that conversation, but also say, hey, we have this person here today who can help you, and it's probably gonna get better within 4 weeks if you see them. And so that's a pretty reliable estimate.
Ryan, your original question and the subsequent discussion reminds me that, in the day when we used to teach benzodiazepines, it was exactly what we're hearing right now, so many years later. And that is, if it's everyday anxiety, then they're not really appropriate. On the other hand, if you're had a very sad incident in your life and you had to get through the funeral, then they were appropriate, but you would stop it soon after that because you had to go through the stages of mourning and all those things. And I think I'm hearing the same thing. If there's some therapy that's a little better but takes a little slower onset, then the benzos are good for a short period of time. And we're back to day one. That's always the way we taught them. But I guess there's been a little creep in the duration of what's short, and it's gotten longer and longer and longer. And we used to always say, well, that's not good. You're just putting off the inevitable of what you have to face and deal with. And it sounds like now we have some really good therapies, and maybe that's going to be a possible answer, is that there's a radical idea, benzodiazepines for the short term, and then you transition into something a little slower onset, but is going to have more long-lasting effect without the deleterious effects. Yes?
I'd like to bring a little reality into our discussion. First of all, we really need integrated healthcare systems. Maybe we won't get that until we get rid of the whole concept that psyche and soma are actually separate things. But that's, we live in Western civilization, so we have to deal with that. But the idea of having behavioral health people working very closely with primary care people is very, very important. Maybe at some point a primary care person will not be a physician or a nurse practitioner, but will also become be a therapist and have a much greater ability to work with the whole person. The second thing is, since we're talking about integrated things, I spend a lot of time just keeping a log of who's doing CBT and DBT and EMDR and who's doing mindfulness in this town. And even though I do that, it's very, very hard getting people who are working or parents out to therapy or getting the therapy covered or getting actually a good therapist. And there are so many other things that are impediments to people getting the type of care. And you know what? If you're going to lose your job because you're not getting sleep and you come into an office panicked, you probably will wind up getting even a short term of benzodiazepines. So what I'm really saying is that we really have to always remember that there's a very large picture here, that health is biopsychosocial and existential, and that researchers alone and physicians alone aren't going to solve anything, just like a cop is not going to solve crime, because we're dealing with a very organic situation.
Sure.
Which leads to all of the anxiety that we see.
You know, I'm curious now, of the audience that's here, I know we have some folks from the psychiatry department, family and community medicine, I know we have pharmacy, is anybody from a
Dr.
different?
Roffa, if I may, this is a great segue, because this was a question that I had, and one of the reasons we're here today is because of advocacy. And I guess my question to the scientists and the people who are the professionals in this room is, we have a public policy issue, and salient to the news coming out yesterday about Purdue now filing for bankruptcy, we have a huge problem with money really being one of the drivers of what's happening. So I would be curious to hear from the panel and anyone who would like to offer anything that they're doing, or maybe if their expertise is being tapped for any kind of testimony or policy driving change that can really start to address exactly what you said. This is what we have to do. We have to treat the whole person. And as a layperson, we hear the headlines, but the background is there's so much going on here, and I'd really love to hear from anybody who can offer any of what they're doing from a public policy point of view.
Maybe you want to talk about the 2 national programs?
For the benzos? Well, just in the limited area, the benzodiazepine, we would ultimately like to have, the FDA people in the room as well, hearing these stories, and if nothing else, just to concede that we don't know what's going on after 4 weeks, and change the label or something like that. So as our next step, this step is to sort of disseminate some of the information and to get some feedback from people, to sponsor research. And then the other thing we're going to be doing in the next year is we're going to convene 2 panels of ex-FDA folks and people who are tied into the FDA, and then ask their advice. So we're going to have 2 of these, and Todd will be there. And the first one, we're going to say, well, this is where we are now. We're going to present what we just presented, change the label. And, what would you think about if we approach the current FDA people? And then, based on what they say, we're going to fine-tune it, and then go back, ask them the second time, and then hopefully we'll be ready to go in front of the FDA and have them change the label. And we're also going almost direct-to-consumer sort of thing. We're thinking about having this on, we got to go with the times. And so, there are radio stations we're talking about, and there's social media, and all these things to have the patient, again, to empower the patients. and to say, ask. Just ask, why am I still on this? And things of that nature. So that's a tiny little area, but I think, as Bernie has pointed out, in some ways this reminds him of 10 years ago in the opioid crisis. A lot of similarities. But in the benzos, but we don't want to wait 10 years. He doesn't want to wait 10 years for this to explode like the opioid crisis did. He wants to cut it off ahead of time.
But funny you should ask. So at the Alliance for Benzodiazepine Best Practices, we are organizing and continue to look at a strategy in relation to that. And we're looking for mechanisms to leverage the greatest possible change in prescribing behavior over time. And we're out there giving talks and so forth, but it's a fairly narrow audience, and usually the audience is already on board to some degree that arrives at a benzodiazepine presentation, that sort of thing. So a lot of what we're doing is organizing around showing up in front of the FDA and DEA to look at 4, maybe 5 different things. It's a black box warning, it's rescheduling, the potential for that. It's the medication guide, which is essentially the informed consent, and REMS, risk evaluation mitigation strategies, that if put into play by way of the 2008 act that allows enabling act that allows the FDA to do this, it would compel the pharmaceutical industry to fund the REMS process in that regard. We want to land in front of the FDA probably in a couple years once we have the groundwork established. And so we want to create a lot of volume around this particular issue, create essential information as well. We want to identify the problems that benzodiazepine survivors had. Again, it's a group that's hidden in plain sight because they've left our practices. They're working together among themselves, but not necessarily we as in primary care or in psychiatry are necessarily seeing the bulk of these individuals and say, oh, that's really extremely rare. No, not the case. There are thousands and thousands out there in relation to that. So we're designing a strategy in relation to that. The other thing that I'm doing is looking through the options out there and kind of taking a lead from the opioid crisis in terms of what works. And so what are the strategies that are prescriber-focused, patient-focused, policy-focused, public health-focused, pharmacy-focused? What has worked in those particular domains in the past, and can that be used in this particular endeavor as well? One of the problems that we're going to be facing with the opioid crisis is that the crisis will go away, will be supplanted by something else, or the perception of the crisis will go away, and we better have in our back pocket the 3 or 4 things that really worked, evidence-based. And the big problem with a lot of the interventions that we have out there is that we're not, if it's a legislated thing, they're not doing a fiscal note attached to that to say, we're going to do a study to sort this out or not. And so, we at the Alliance are looking to kind of pull this together because, funds are really quite limited in that regard. Incidentally, if you're interested in assisting us, that's we're all over that. So bodies and money in this particular process to multiply the kind of messaging that we have there, I think, is really critical. But in 2 years, we want to land in front of the FDA. We do recognize who the opponents are probably going to be when we land there. A previous petition failed in relation to benzodiazepine and also with sedative hypnotics. We're looking at that to make sure that we don't do the same mistakes or have a kind of a better argument when we arrive.
Yeah,
my take on it is that we're at the stage where we need to have conversations for those that are interested individuals. I really believe that, and I have lots of empathy for the patient that was described, or the scenario that was described. I think right now we're at a very fundamental level of understanding, and we need to increase our understanding. And from my standpoint, I'm the chairman of Pain Week, which is the largest pain conference in the U.S., and I got one of these programs on just to see what my colleagues thought about it. And 2 years in a row now, 300 plus people are in the room. And they have a myriad of different programs they could pick from, which are more pain-related, but they want to know about this. So that's interesting, and that means that there's a lot of room to have very good discussions. I don't share in the overture that we need to, force the issue. We need to first define the issue with real science, real evidence, look at the impact of what it could have on patients in general, assimilate real-world evidence, because there's a lot of anecdotal real-world evidence out there, and now we're more adept to look at that, and then understand who that special population may be at risk. And I'm more excited about, could there be a genetic marker that we haven't looked at? Is there something else that we need to be thinking about so that it's more of a focused, concentrated effort in trying to talk to the different stakeholders, and only one of them is the FDA. There's a CDC, there's the FDA Safe Use Initiative. What about the VA? Right? I mean, there's big VA influence here, right? I was a VA grant reviewer, senior reviewer for years. I mean, these are all things that we need to sort of start the conversation. And that's what this was meant to be, is to start the conversation. This is a pilot program for awareness. And we do this in a very two basic, simple ways. In a sense, we want to find a cap, the knowledge, attitude, and practice of what's going on, right? And then we want to find a BAP, which is a belief, attitude, and perception from the patient. And you know what you're going to find out? That we're not in line with what they want or they think is best for them. That's always the case, I think. So we just need to apply those simple, broad strokes and then build evidence to support position one way or another. It's good to have people on both sides of the fence. That's how you pressure test ideas, right? You don't want to cause mass hysteria. You want to be able, though, to answer simple types of questions as best as you can with real evidence, because we know that there are people out there, maybe a subset of people, that are not benefiting from this, and that's not good, right? So that's my 2 cents.
Yeah, and I'm going to reiterate the invitation to have you join us. Don't feel shy that, well, you're not studying this or you don't have a lab or whatever. All of you could contribute something. There's some reason why you're all here today. And so if you have, anecdotal evidence or you have patients you could tell us about, we can transform that into a review article or papers or something. So whatever it is you have, we would be delighted if you would forward that information to us to whatever extent you want to participate. It would be extremely, extremely valuable. So.
Steal my slides, do whatever you want. You're welcome to any of this. And I imagine this is a group that's speaking to a variety of populations. The whole idea is to kind of multiply and leverage the message over time in populations of prescribers.
So with regard to policy, I'm going to introduce a different angle here, which has to do with understanding anxiety and especially from a basic science perspective, when we're thinking about how to understand anxiety, I think it's important to keep in mind what I'm going to point out here is that anxiety is a developmental phenomena in creatures, be they rats or human beings. And we know that there are epigenetic differences that occur based on rearing of rats. And it's in the, CRH receptors in the brain. So we know from the get-go that there are some people who are much more at risk of getting anxiety than others, who are going to be more at risk for all these downstream problems. What we also have from a policy perspective is a whole body of research that's been funded by the National Institutes of Mental Health for prevention of emotional disorders. And these are prevention programs that are done with pregnant teens who have had histories of abuse and who aren't likely to be good parents. We know how to intervene and to prevent the bad outcomes with their kids. We know how to do programs for educating and training parents to be responsive to those more at-risk kids. We know how to do preventive interventions in schools to reduce the risk of mental illness, specifically regarding things like mindfulness and teaching kids about their emotions. So I would say if we back this way up and think about risk, the other big policy issue that needs to be tackled is that of abuse, because we know that there's an epidemic of child abuse in this country. And of course, those are the kids that are going to grow up and be suicidal and need benzodiazepines and not be able to work. So as we think about the policies for the adults that are already getting addicted to the benzodiazepines, I think it's also important to think about how can we understand the contributions of trauma and, poverty and social dysfunction when we're thinking about policy, to make sense of this. And then, like I said, for the animal researchers, I'd really love to know if rats who have maternal deprivation are differently conditioned when they go into the dark with a benzo or not. Because I think that's probably, it could make a big difference.
The answer is yes.
Oh, that's good to know.
You're absolutely right. And so there's categories of primary prevention, secondary prevention, management, and then management as well. And all of those things need to come into play. And we all have a different piece of this that we can invest ourselves in. I mean, it's really critical. And I think you're absolutely right. Trauma is really significant. And, we see the play, and literature seems to be separated there too. We hear a lot about polyvagal contributions to trauma in one set of literature, and if you look in the medical set of literature, it's a term that's almost absent. You get one page on PubMed, but it's a highly relevant issue. And frankly, what I think is happening here is that those mechanisms are put into play by the use of benzodiazepines. And you have a peripheral component that perhaps we can better address than the central component, because the central component, if we're using GABA-active agents as opposed to non-pharmacologics, we've got potential problems down the way that we just don't even know about. Use a lot of gabapentin, and 20 years from now we're thinking, oh my gosh, that was a really bad idea kind of going on there. But there are peripheral mechanisms like what we were talking about earlier, POTS, postural orthostatic tachycardia syndrome, where you can address some of the peripheral components of that to some degree. And of course, trauma-informed, trauma-responsive kind of processes are going to be really relevant. But the benzo users themselves, just from the benzodiazepine exposure, I would offer is a traumatic event all by itself, much less the circumstances, that they face as they're trying to taper.
I think the other big area we had was in discussion. We had a couple pharmacists from the VA. You cannot convince me that people who have been over to war, their bodies are the same as the bodies of people who have not. And I don't think we think of it that way. We somehow try to treat them, if we treat them at all, as if the physiology is exactly the same. So talk about epigenetic changes. Come on. I mean, we got to start studying that. Again, I think we're flying in the dark when we pretend that we're treating these people as if they were, high school kids who just have, the worst thing that's happened was they lost $1 at the mall or something like that,
I would like, for addressing Dr. Roffa, you had mentioned that there was very few of your patients that you would have considered addicted to, was it Dr. Wright?
Yeah, I don't have any. Mine are all rats and mice, but...
Oh, well. So I'm sorry, so Dr. Wright, could you expand on that a little bit? I work with low-income substance use disordered individuals, and polysubstance abuse was mentioned in here, and I can say that a very high percentage of any of the individuals who have substance use disorders also use benzodiazepines. And we were just talking about trauma and how childhood trauma can increase substance use disorders, anxiety, and the need to kind of numb those emotions instead of going through the coping skills, whether you ever learned them or not, to deal with them. So I'm just curious that you had mentioned only one individual. And my second question to what you had said is, you had mentioned that individual, you noticed the addiction because they had a lockbox, and so that medication was actually taken away from them. Is that the case in your other patients as well?
Well, I mentioned the lockbox because there's evidence of the disease of addiction where they were so compelled to use it despite making a commitment that appeared to be an authentic commitment to taper off the medicine. They went into the lockbox in the backside by tapping out the pin, not on the locked side, and that sort of thing. So addiction is hard, and I think that the benzodiazepine experience is really going to tell us something different about how maybe DSM-6 addresses this, and that is, so what is behind all of this neurophysiologically is this craving. Addiction, Robinson and Berridge kind of outlined a model for addiction that I think is really valuable, and that's called incentive salience. So the theme goes, and I sign on to this, is that addiction is not about liking a drug, it's about needing a drug. And so the liking part is sort of the nucleus accumbens, the release of dopamine. Boy, I really like that. But even in all of our personal experiences, we really, really like something and then go to something else. We really, really like music or really, really like theater. And we really like sexual activity. We go do our job. We're very interested in that too, and come back to that without this compulsion to re-up that on a continuous basis in a way that's really destructive. And so individuals that have benzodiazepine challenges, they are, one of the criteria is, can't stop easily or tries to stop or unsuccessful. Well, the reason behind that for addiction is craving. I really need that drug. It's sort of like being underwater and not coming up for air, and eventually it doesn't work that way. I'm not coming up for drugs, but you do. And so the vast majority of individuals that are using benzodiazepines in the substance use disorder environment are doing that adjunctively to amp up the opioid effect, amp up the alcohol effect, or ameliorate the withdrawal effects that these situations, or I'm just too intensely high with the cocaine or whatever. And so they modify that, they mix and match in relation to that. But in terms of the agent itself, the vast, vast majority of individuals do not increase their dose, don't ask for an increase in dose. Therefore, those of us in the addiction field didn't recognize it as a problem because we saw people with opioids doing this and alcohol doing this, but with the benzos, you get on a dose and the data is there, you stay on that forever, but you can't get off because it's very difficult, and you don't get assistance from individuals in the prescribing environment to be able to do this in a successful way. So the reason behind that is the challenge of withdrawal, not craving.
Not to that, but just on another point, there are other things too I would encourage researchers to think about. We have one individual who came a far way to be with us related to artificial intelligence. And, that's becoming more of a role in different things that we do. So I thank Ryan for coming out to talk about, to be here and listen. But it's these different type of opportunities too. It's not just, as Bob said, in the lab or in the clinic per se. It's utilizing all these different types of opportunities that may allow us to have better algorithms, right? Better ways of checking to see if someone's manifesting certain types of physical or psychological behavioral issues, right? And that might able to drive us. So think outside the box. Blue sky this, because it's really open. And it really has a great opportunities for creative, innovative people to make a difference in this particular domain.
Even though we maybe have put the addiction issue to bed, studies have shown, I understand, that when people are taking benzodiazepines, that they feel better, sometimes a little euphoric. And there's a possibility then that they are confusing this feeling with actually well-being or with not having anxiety. So that's not really addiction, but it's a type of learning that is leading to maybe nosocomial aberrant medication taking, but something which I think we as practitioners have to deal with. It was the same thing like when people took, I guess, the old formulation of OxyContin. There was a lot of that released at first, and maybe it was a change in blood levels which they actually confused for being pain relief. And therefore, anything else that you did, they thought, no, this medicine isn't working. So is that your impression, though, that that could actually be happening? Very mild euphoric effect that the patient is confusing with an anxiolytic type of response.
Yeah.
I think there's no question that that's the case. But again, liking is not directly correlated with addiction. I mean, we kind of posit addiction sort of at the nucleus accumbens, and certainly that's part of it. One of the entree issues is liking something, and then it evolves into needing something over a particular period of time. But it really is not a single center. It is the social learning aspect. That has made me more comfortable. So we have memory. We have at the locus coeruleus, avoidance of withdrawal. The prefrontal cortex actually may subserve a stronger element in relation to addiction. That's the executive function, the no part of the brain that counteracts the yes part of the brain. Am I going to sit around and listen to music or have sex all day, or am I going to go to work? Those kind of decision-making processes. And so the brain truly becomes hijacked, and I think the orbital frontal cortex may be more central in that regard. But I see this as actually not a center, but it's sort of like a hologram between, all the projections there's projection from the nucleus accumbens that's observed by the ventral tegmental area, and amygdala, and the insula, and the anterior cingulate, and the orbital frontal. It projects together and says addiction together. And so, yeah, absolutely, euphoria can be misunderstood in relation to that. I had a patient who came in and we changed to Opana extended release, and he said, "Yeah, I don't like it that much." He said, "Well, why not?" "Well, I don't get that bump in the morning, but my wife likes it because I'm not irritable." And I thought, well, okay, how's your pain? "Oh, it's great." So there is that other effect. Now, emotional relief and a high and so forth, those are concerns in relation to, but they're predecessors to addiction. They're not equivalent to addiction. So when I see that somebody's using an opioid or another agent for non-indicated reasons, I'm not real excited about that, but it's not necessarily addiction.
Yeah, I think there are a lot of other things in play. I think that I remember growing up as a kid, Mother's Little Helper, the Rolling Stones, right? So what about all the rest of that? I mean, you're inundated on TV, on social media, and all these other things that's got to have an impact on someone too. And they just feel like, look, it's easier, hey, it worked for my friend, it'll help me. I'm
a preclinical guy. I love discussions of receptors and all that. We can talk about the drug, we can blame the drug, we could talk about the parts of the brain. I think we got to go back to the number of people who are abused in this country and every other country. And when you listen to them, even on opioids, they rarely say, "Oh, party time." They say, "I feel okay for a little while." And I think until we are willing to address the person, to me, the drug is what they're using. They would, if it wasn't for the opioids, they'd use something else. If it wasn't for the benzodiazepines, they'd use something else. I think until we admit that there may be 40%, I'm going to say 40%, of the population of almost every country that's physically, sexually, or emotionally abused. These people are hurting. And I think that's where we need to start equally as important as looking at the physiological response. All right, enough of that.
In that regard, the disease of addiction is a disease of a relationship. It's not posited in the substance alone. Otherwise, all of us that got Percocet would be addicted. It's not posited in the person alone, it's posited in the relationship between the two. And in addiction, fundamentally what we are doing is we are finding a new relationship with life, with meaning, hope, and purpose that supplants this particular thing, that has more durability and efficacy in terms of this is what I want my life to be all about, rather than the destructive decline that occurs in active use circumstances.
Not a question, just a quick comment to the other comment. There's an interesting body of literature coming out on addiction as a learning disorder. There was a New England Journal of Medicine article from 2018, and also a really great book, Unbroken Brain, by a former cocaine user who also is autistic. And I feel like it made a lot of sense to me as I was reading through the book, because when you look, people that smoke cigarettes, that behavior is repeated several times a day, so that's harder to break that addiction. But then when you look at people who use cocaine or heroin, a smaller number of them progress to addiction. So I think it's really more complicated than just this binds that, which causes the release of dopamine. There's more.
So we've struggled in the field of addiction. What is it? Is it self-medication, the Kantian hypothesis, and so forth? And that's not entirely gone away. Taking a medication to solve a problem, it's ineffective in the end, but there's this window of it helped me. Social learning is part of that. So anytime you look at any one of these centers, if you're looking at the locus ceruleus or the orbital frontal cortex, you will find stuff that is relevant to addiction. The problem is in isolation, they probably are insufficient without the other things. So social learning, the euphoric component somewhere in that regard. Chris Farley said, the progression of addiction was I laughed, I cried, I wet my pants, and that's kind of how this goes. It's not like I'm having fun all the time. Fun is not happening here.
Comments and questions about addiction, but remember there are other type of physiological manifestations or pathophysiological manifestations that we brought up, many that Carrie exhibited. So we have to focus on those too, right? This concept that these receptors may be on mitochondria, that's a big issue, right? So, addiction is part of this. That's why what I tried to do in my lecture is just saw a smattering of different things. Overdose, this issue of addiction, physical dependence. Guys to go and blue sky it, as I said, and think about all the other things that we mentioned today. That really groundbreaking data that Bob shared with you, where these receptors are now all over the body. We just didn't call them that, right? From drug discovery, that should be really interesting. From pathophysiology, that should be really interesting. And that's really, hopefully, the impetus to get everybody excited and moving on this target. And again, there are no sides here. Right? There's no pro or cons. It's just, let's get a consensus on something. Go ahead. Fody?
To that end, what I would hope to see happen in the future as we're developing provider education, and that's kind of one way to skirt policy, is just make sure that the addiction piece of it, the physiological, the biological, that all enters into the provider education. And as we see the behavioral health and the medical fields kind of come together, that the medical providers really can be that first line of identifying whether or not there is kind of an underlying issue. And then it goes, what was said before, if you have somebody who's addicted, most likely there's many barriers to going to CBT or going to any type of therapy. And so just kind of adding that to the provider education piece.
We have some really big hurdles. You know, we live in an environment that supports procedural interventions rather than cognitive interventions, and that simply has to change. And, you know, we're kind of in that circumstance right now where it's going to be a zero-sum game. In order to increase reimbursement for primary care behavioral health, something is going to have to be taken away because it's not going to be a circumstance where you're going to add to. Accepting, you know, I think there's an opening with regards to value-based medicine and outcomes-based medicine, you know, in terms of those economic paradigms, but that's only going to go so far. We've got a lot to look at in terms of procedures almost versus cognitive services, and how are we going to work our way through that without upsetting terribly our colleagues.
The mole has a question.
So one of the concerns as a practicing pain physician I have is convincing people to seek behavioral health. It's pill and procedure is easy. This is much harder, takes a lot of work on your part, and there is some cultural element in that, depending upon who you talk to. And that, to me, is one of the biggest. I've tried my best to. We work with the pain psychologist, and numerous times I've emphasized to the patient that you need to go and seek their health. And the people who actually did and they were motivated, they did very well. People who didn't want, which is overwhelming majority, they just didn't want to even go. Forget about it trying. You know. So, and that is a huge problem, and that's a cultural problem. It's not just about medical education.
Mm-hmm. Mm-hmm.
So the strategy I've used is to leverage patients and say, you know, we don't know that the opioids are not contributing to pain. We don't know if the benzos are not contributing to anxiety. So we're going to find out by decreasing that. By the way, we have these other behavioral health strategies that you can get involved in while we're doing this. And so the leveraging is to, we're going to make these reductions and, you know, yes, a proportion of these individuals, maybe a lot of them will leave and go elsewhere, but as more of us do this and the theme is replicated through prescribing environments, I think that might help.
Well, it's my unpleasant duty to say we've come to the end. Hopefully it's just temporary. Maybe we'll all continue this somehow. But I want to thank again the university. I mean, what a gorgeous venue. To Manon, to the dean who came out, to Ross, to everybody back there who's done a fantastic job. To
Arian, Bernie.
Okay, yeah, you want to take, okay, go ahead.
No, everybody has been wonderful in the engaged conversation.
Those are drink spots? Yeah. Yeah, so one thing, as part of the master ceremony, let's have a drink. Thank you all for your input. Thank you.